strengthen us with purpose, and inspire us to serve humanity with excellence and integrity. These things we ask in no other name but your name. Amen.
Thank you, Sister Mackenzie. And now we are very pleased to have the director of the School of Clinical Medicine and Research here in the Bahamas, Dr. Sabrika Pinder Butler, who is a family medicine practitioner and who has proctored many of us through the family medicine rotation and program here at this School of Clinical Medicine and Research. So, Director, we welcome you. Thank you.
Good morning again, everyone. Thank you for welcoming me. Truly, I wish to congratulate the Department of Surgery, Dr. Grimes, as well as Dr. Lucas, for leading in this conference. We know that it will be a great success, and we always promote continued medical education for our faculty as well as our students, medical students, and postgraduate students. So we are very, very delighted to know that this is the third annual event, and we look forward to more partnerships with the department and other departments as we continue to promote education throughout the Commonwealth of the Bahamas and the region as well. So once again, congratulations, and we look forward to a wonderful time with you.
Thank you. And another welcoming remark we will ask the director of the Department of Surgery, Dr. Valentine Grimes, consultant orthopedic and spine surgeon, to welcome us all to this conference. Dr. Grimes.
Thank you. Thank you, Dr. Nordish. Thank you, everyone. So from the Department of Surgery, I'd like to welcome you all to the third annual Minimally Invasive Workshop. I want to personally thank Dr. Lucas for leading the charge. He has made my life easy, and that he would throw things out and so on. But his passion for developing this workshop and conference is obvious, and it's grown every year. I would also like those of you who have answered a call from him to participate in this year's conference. Appreciate it, because we have a wealth of knowledge, both locally and visiting surgeons who have come in to share their local and international expertise. And so let's get going, and appreciate it and welcome. Thank you.
Thank you very much. Okay, let's get this show on the road. First, I'd like to say something. I came into this room yesterday to set up, and I saw these two white boxes on the wall, and I decided to see if they worked, and they do. And since setting up today, I asked one of our residents if she knew what those white boxes were. And she did. It's a light box. Do you know what we use it for? Yes, for looking at x-rays. Have you ever used it? No, I have not. And there are those of us in this room, I'm probably among the last, who would remember orthopedic M&M, where we had to go to the radiology department, pull all of the x-rays by alphabetical order, and bring them here, place them on the light box, and discuss fractures. So that was then, and this is now. How do we discuss it now? Well, we share pictures on call on WhatsApp. There used to be an orthopedic surgeon who did not have WhatsApp. You had to literally describe the fracture, which means you had to know what you were talking about when you called him. He didn't have WhatsApp. He wasn't accepting pictures, right? But now we're in this digital age where we can share things in an instant, where we can record our surgeries, where we can see things in 360. And progress is good. We have developed in the world and certainly in this region. And what we want to do through this conference is show why advocacy for minimally invasive procedures is so important. As a junior physician, I'm sure we all know, we book a laparoscopic procedure and the nurses roll their eyes and you're going to take forever and this is going to be too long and the setup takes 30 minutes already and why don't you just open them? This is complicated. Because just opening a patient isn't just opening the patient, right? There's so many complications that come with open surgery and recovery time is so much longer. But more than that, because we need to learn and grow and develop just like the rest of the world. And so let's stand our ground. Let's push Princess Margaret, the Bahamas, and the region further. And let's advocate for minimally invasive surgery. I heard this song yesterday, and I decided to make up a little jingle for us. Okay. So it goes, happiness is learning how to do MIS. We can cut you more and scar less. Yeah? I like it. Okay. So minimally invasive surgery and advocacy. Our first speaker today, we are so happy to welcome Dr. Saleh Griffith, who will be speaking on advocacy and collaboration, a strategic framework for minimally invasive techniques in Caribbean island nations. And Dr. Saleh Griffith is a consultant general surgeon and laparoscopic surgeon who hails from Barbados. He is an advanced general and laparoscopic surgeon with extensive international training and over 2 decades of experience. He began his medical career in 2000 and commenced his general surgical training in 2002. During his training, he became a member of the Royal College of Surgeons in Edinburgh, and over the course of his residency, developed an interest in minimally invasive surgery. He earned diplomas in laparoscopic surgery in the University of Strasbourg. He undertook additional elective training in Spain. He then returned to the Caribbean and completed his general surgery and bariatric surgery at the university. His general surgery training in 2009, but he did a clinical fellowship in general and bariatric surgery at the University of Alberta in 2011. Since September of that year, he's been practicing in Barbados as medical director of Surgical Solutions Incorporated. He's a consultant surgeon at the Queen Elizabeth Hospital and an associate lecturer at the University of the West Indies, Cave Hill. As of August 2020, Dr. Griffith was appointed head of the Department of Surgery at Queen Elizabeth Hospital, a post he still holds. In 2021, he became the founding director of the Caribbean Colon Cancer Initiative, which is a research-led and nonprofit organization focusing on colorectal cancer in persons of African descent. He has used this platform to perform many community health initiatives, research, and surgical resident training to advance the management of colorectal cancer in the region. And it is true that history belongs to the author. And so if we're not researching ourselves and if we're not writing it down, as Dr. Saleh Griffith is trying to pioneer and doing for our region, then it doesn't exist. And we have so much wonderful pathology that we do need to contribute to the world literature. So thank you, Dr. Griffith, for the work that you're doing. And we welcome you to this conference and to be our keynote and first speaker.
Thank you, Dr. Nottage. Thank you, everybody. Well, I hope I can live up to that intro. Yes? No, the truth is that I was that today to give this keynote address. Hold on 1 minute, we're having an IT issue. Okay, so just keep advancing. Okay, so we're finally good to go. So I changed the title. I made it a little smaller. I made it a little more easily digestible. Positioning small island developing states for success in the MIS revolution. Why did I use this topic? First of all, the Caribbean, we are vulnerable environments. We are all small island developing states. Literally, I think when I was about 15 years old, the first small island developing state conference that they had sponsored by the UN was held in Barbados at the community college. And I remember going there, walking through the displays and trying to figure out something. I always wanted to figure out what distinguished between a developed state and a developing state. And to this day, I've been having a few issues with that particular concept. So I'm hoping that by the time we end this talk, some of those concepts will be shared with you, and some of these concepts we would at least have implanted in the minds of my colleagues here. Yeah, I have no disclosures. I'm still on the lookout for that bag. This is almost 30 years. Come on, bust up. Time to bust me, no? Anyhow. The true confession is I will always and I will die a radical thinker. Yes? I think pretty much for those that have known me for many years, like I always have to struggle. I have to call him Dr. Halliday. I have to think about it because the name that comes to mind I can't share in this environment. But I've always lived on a little bit on that edge. And the reason why this is important to this particular talk is because of what Dr. Nottage said earlier. Dr. Nottage pointed to that board. And to be honest, it made me think. Over the last year or two, I have been working with the concept that we are in fact the middle children. Who are we? The persons that are about 20 something to 30 years out of medical school. And I say that because the first set of surgeons that were in the Caribbean came from outside. And in about the 80s, I think it was, they then started a surgical program. The three heads of that program were Prof. Waldron, Prof. Fletcher, I think, Dr. Dukenny, and I think probably Dr. Professor Narain Singh might have been the foundational heads of that. With that, they trained the group of surgeons that were first Caribbean trained. Of those, they trained us. And so those were probably the big brothers in the system, the ones who came after that were trained by the founders. They trained us, and we trained the Nottages of this world. Yes? And Nottage is very interesting to me. Nottage is a star. No one knows why she is a star, but she was a star because of a meeting that we had where her discussion was interesting. And I knew she was a star based upon her delivery, and she proved it yet again today. If you can DJ about MIS, you know. So in truth, it doesn't do the audio. So the audio does not come up. I'm begging you now. Was watching you when you was paving the town. I copied your cadence, I mirrored your style. I studied the grace, I'm the greatest right now. So, Middle Child by J. Cole. In that particular discussion, he says he is speaking to the younger ones, yes? And he is appreciating that they are getting the bag, yes? For that, I am here. Dr. Lucas brought me here so that I can have a little discussion about how y'all youngsters can bring this to the forefront. I appreciate what was done by the older heads, but unfortunately that time is over. And realistically, middle children always have an issue. Our issue is that we always got a point to prove. We were not the first, and so we had to follow the first, and we had to listen to them. And I didn't know this because I'm actually the eldest, so I introduced myself in theater. I know when they have the checkout, and I could tell sister was a sister from I smelt the sister on her. Yeah. Yeah. I introduced myself as Saleh the firstborn. So I did not have that particular issue. But I have a middle son. And the middle son is always very different. He's much more sociable. Yes. He's somewhat rebellious. But he's always, I think, having a little chip because he's not the first. And in a way, he was the youngest until the last one came. And in the case of my middle son, that was about 16 to 17 years, yes? So he got middle child syndrome big time, yes? So at that point in time, yeah, as a middle child now in the context of surgery, I believe it is necessary that I speak more so to my younger brothers than to my older brothers. So this is not for you. This is not even for my co-equals like Dr. Francis and Dr. Halliday. I almost called you. Yes, but realistically, this is for the youngsters. Now, what is most interesting? So this particular individual on the screen, can anybody, well, it says it. Oh, it's glitching. Oh, wow. Is it? I think we're having a Haiti problem here again, boy, Darren. Okay, no worries. So on the screen, if you get to see it, that's Mr. Mark Carney. Mr. Mark Carney is the Prime Minister of Canada. And in probably the most interesting speech that was delivered in the last 10 years. And I say 10 years because probably one before that that interested me to that degree was Bill Clinton, where he quoted The Prince by Machiavelli. Mark Carney discusses what we in the Caribbean should have known unless we deluded ourselves. And that is that in reality, there is no, one would argue, international justice. The power politics, the era of power politics has returned. He made three critical statements in that, and I quoted them here. The first one, he said it in French, and the translation in English is not so grammatically clean. But it says, the power of the lesser power starts with honesty. You must be honest. Now, this is very hard. This is very hard. It is very hard to stand here and say to industry, for example, who is sponsoring, I'm sure, my stay here and has sponsored the conference to some degree, that what y'all are doing in the region is not really so right. It is hard to speak to the administrators and say, boy, in reality, I see where we want to go and I see your issues. Let me give them a minute because I'm. Okay, so it is hard to speak the truth. It is an offense, but never a shame. So one of the truths is that we are in the midst of a rupture. That particular rupture is most manifest with what's going on in Iran. And not to be a political, or make this talk political, but that has direct ramifications for us in this region, in small island developing states that are logistically difficult to reach. I live in a country that was originally formed as a prison colony. So before there was, there was the home of slavery, it was where the slave code actually began. But prior to that, it was a prison colony. And it was a prison colony because it was hard to reach. So how in this era where we're gonna have logistical issues in this small island climate vulnerable state, are we gonna be able to survive more or less move forward MIS? And so having to think about this caused me to basically come up with a few ideas that I would like to share with you here now. And then the final point. The final point was something that I found, let's say, a couple of years ago. They were discussing the weakest militaries in the world. Yes? And so the final point relates to the statement made by Carney, which exemplifies power politics itself. He says, a country that can't feed itself, fuel itself, or defend itself has few options. When the rules no longer protect you, you must protect yourself. Now, militarily, and I will have to say, the Bahamas and Barbados are at most the 10 most weakest militaries in the world. There's an infographic on that. Yes? So we really can't defend ourselves militarily. Realistically, however, what we can defend ourselves with is resilience. We must be resilient. We must create resilient platforms. So what is the desired destination? I put this in there. This one was for Wesley. Yeah? The desired, I made it. I made sure I got a Da Vinci in there, Wesley. I know. So the desired destination is a Da Vinci or something similar or some kind of robot, because in reality, I believe robotic surgery is the future of surgery. I have done MIS for the last, when I started, I would say when I went to the UK prior to finishing around 2008, but I became a MIS, a fully certified advanced MIS surgeon in 2011. So let's say the last 17, 16, 15, 15 years, I've been doing advanced MIS. Initially, when I came back to Barbados, there was basically no one who could do advanced procedures. So no one could follow advanced procedures. So literally I spent a lot of time trying to train the residents. And if you've ever been doing a low anterior resection with a junior who don't know how to keep the camera in the middle, you understand how that feels, yes? Yeah, man. My shoulders feel it, my wrists feel it. Yeah, I'll be honest with you. After all these years, I have significant arthritic issues related to MIS. Yes, it's a love hate. But in reality, the robot solves all of that. It's an ergonomic setup. You sit on a console, you get 3-dimensional views as opposed to 2-dimensional views. You got 360 rotation. The robot is the future. The problem is that the robot has to get a little cheaper. So where are we now? We're 3 guys in a room. And ironically, this image was taken before either of these 2 guys did fellowship. This were when they were in training. So on my right, I think, is Dr. Padmore. On my left is Dr. Shabir St. John. Padmore is now a HPB surgeon who basically does advanced MIS as well. I mentored him through that. And Dr. Shabir St. John is colorectal, who has a predominantly laparoscopic and endoscopic practice at the moment. So we did move things forward. However, we are still nowhere near the desired destination. Yes, at least not in our jurisdiction. And this is where I think the hope lies in technology. And I like these images. These images, as you can see on the screen, represent a few things. The first one is the slums in Manila. The first series of images on the right. And they have a problem with electrification in the slums in Manila. Yes, they're large, sprawling slums. And as such, they have problems with lighting inside the homes. So at that point, children have problems with school, with education, because it's dark and it's compressed. So what they did is they figured out if they put bleaching water in these PET bottles, cut a hole in the roof and make a attachment for it, they can put this through and it shines, it brings through the sunlight, shines like a light. Cheap, easy, yes, effective. Next one. The next one you see in the background is a man in rural Africa on a cell phone. Now in the back, how you know this is rural? Well, I've been to Africa many times. This is clearly rural. The man he's a hunter. He has a gun in the background. Yes? He fed the shots. But in truth, what is interesting is that the little boy is teaching this man how to use his cell phone. Now, BRICS recently embraced Ethiopia. And the question would be, what pushed Ethiopia and Kenya so far along in terms of their development in the last decade or two? And it boiled down to cell phones. Now, why is that the case? You can't really cross the Serengeti and the Savannah and the Sahara. If you've ever been to the Sahara, I have a picture flying over the Sahara. There's like an ocean of sand. You can't cross that with traditional telephony via lines. It would be ridiculously expensive. But what happened now in places like Kenya was that Kenya is one of the number 1 producers of flowers in the world. I think they're second only to the Netherlands. But if you are a farmer in rural Kenya and you don't know the price in Nairobi, a man could come and buy your flowers for next to nothing. At which point he has the handle and you have the blade. But if you know the price in Nairobi, if you can call and say, Sheikh, what's the price in Nairobi? Then you can make a fair deal for your own flowers in rural Kenya. So the use of technology jumped over what the traditional, but at least the use of portable technology jumped over the telephony to the point where you can actually create significant economic growth. To the point where Indonesia was trying the same thing with balloons. I think there was a time when Google was trying to get cell phone access across Indonesia via balloons. So how are we going to do this? First, we got to begin with capacity building, training. So as I showed in the previous pic, those guys are now MIS surgeons in their own right. Realistically, we need things like this. We need what you're doing here now, Lucas, what we need across the region. We need access to training and robust training. So a couple months ago, the Caribbean Colon Cancer Initiative and Cases collaborated to do a training both on endoscopy and laparoscopy. That's a pig, unfortunately, getting his gallbladder removed. Collaborations are key. So this slide here shows some of the collaborators for that particular meeting. Realistically, you would see collaborators from outside, academic collaborators. We're going to discuss that in a bit. so partnerships with the African Research Group for Oncology, and then a number of industry partners, financial partners, etc. Yeah, because it's necessary to try to create that model going forward. What these collaborations do, they allow us to be able to put on these kind of conferences like what we're having here now. We have various training. The first shot was in Nigeria in a place called Ile-Ife. The other shot to its right is actually the professor from Ile-Ife coming to the cases meeting in November last year. We have the other shot here is one of my colleagues from Dalhousie doing the cells. We're going to discuss that a little later, being really aggressive and pushing the boundaries yet again. So at that particular meeting, everyone was a little disturbed by what this guy was doing, but he proved himself to be correct. We'll discuss cells in an upcoming talk. But in reality, it is by that cross-fertilization of ideas that we're able to create robust, resilient frameworks, not only in our experiences locally, but bringing in environments that might have more and environments that might have less financial backing, and seeing how they were able to put them together to create a model that works. Research. Research is key. Research is the key. So over time, and I am speaking now about, I'm combining a number of things. I am medical director of Surgical Solutions. That's a private entity. And I am the former director of the Caribbean Colon Cancer Initiative. I hand that over to a colleague who went away and basically has I think, a more robust colorectal surgical oncology core than myself, Dr. Alex Doyle, who recently took over as director. And the irony is that he was the first senior research fellow. And so over time, we were able to amass a set of research coming together on colon cancer, the incidence, and so forth. The research matters, and it matters because it allows us to get partnerships. What do I mean? If you are here in the Bahamas and you're doing things, so let me take the most famous example, because Bahamas actually has an example for the region in what to do and what not to do simultaneously, and it relates to the BRCA gene research. So the BRCA gene research was very crucial. It allowed us to say that yes, BRCA is more common in the Bahamas than it was amongst Ashkenazi Jews. However, the fact that the external company provided the kits, and those kits were then known, and they kept the research, allowed that as soon as they had the information they wanted, they were able to pull their research, their data, and move, stop providing the kits. And at that point, the whole system kind of was retarded by that particular motion. So we should learn by this. And the truth is, fool me once, shame on you. Fool me twice, shame on me. So at the point where we are doing research, we need to hold on to our data. We need to hold on to our data, or we need to make robust relationships going forward with respect to, if you're going to hold our data, then you have to at least be providing us the means by which we're able to do whatever test it was that we were doing going forward. So research allows one for collaborations by having data that says, hey, this is what we have. And it also allows for us to lobby governmental agencies, lobby other agencies towards funding. And I'll discuss that in a moment. Well, in fact, immediately. Lobbying and advocacy. Yes? No. The first group I said is the government. Government. Yes? That's an interesting lobby. Yes? Public opinion. Now, the truth is, public opinion might in fact be the most powerful of the lobbying groups. Why? If anybody knows the history of laparoscopic cholecystectomy, so that's probably the most common procedure laparoscopically anywhere in the world. And in fact, I don't know who are residents here, but I'd be surprised if many of you outside of our Whipples saw an open gallbladder. If I can say, back in the day, literally, I saw my first lap chole in year 3 or year 3 of surgical training. Yes, we had one lap chole, and I remember Dr. Ramesh, yes, coming up and presenting in Barbados. They had done 200 and something lap choles. I said 200 and something lap choles. Yes, I was at the Kingston Public Hospital at the time. That was an unimaginable number to me. Yes, but now lap choles are pretty much ubiquitous. How did lap chole become so popular? Yes? If anybody knows, lap choles, there was not much evidence to support lap choles at its origin. Yes? But if you think about it, the vast majority of persons who require gallbladder surgery are women of young to middle age. And the old cut used to be one hell of a thing. Yes? So if you imagine that, no one wanted that. So at the time, once lap chole came in, everybody was like, hold on, I want this thing where I don't have this massive cut under my rib cage. So public opinion drove laparoscopic cholecystectomy. Public opinion also drove robotics. Because I'm going to tell you, a very good friend of ours from St. Kitts as well, Mark Grant, did trauma surgery as a fellowship. And he's currently predominantly a robotic surgeon. Because when he finished, robots were coming in. He started to push. This is in the US. He started to push with the robotics because everybody wanted to get surgery with a robot. Yes, robots are publicly popular. Yes, so realistically, public opinion probably is the most important of the advocacy targets. Academic affiliates, literally, that's also necessary because research can be used to drive public opinion and it can be used to drive governmental opinion. I say governmental buy-in is unlikely. Yes? No. One of the interesting things is Wesley, Dr. Francis, is he's quietly one of the most interesting characters amongst my group. And I say my group, meaning the middle children, yes, in surgery in the region. Because Wesley always has a very different way of looking at things. Yes? Yeah, he did an MBA, and literally I take my hat off to him. Yeah. So at that point, we had a discussion just 2 days ago over dinner that caused me to think about it from the government side. I literally never thought about it before. So budgetary constraints are one. We know about 6% of the GDP of Barbados, for example, is spent on NCDs. Yes. I know 66.7% of the medical funding in St. Lucia is probably spent also on hypertension and diabetes management. So where is the money for the robot, man? Yeah? Realistically, yeah, they could put it, but would it amortize itself within the election cycle? Because you know that these things are always 5 years, and I know you're all about to enter one. I see the signs on the wall. Yes? And I've heard some promises are made, and promises are always made around that time, you know what I mean? But realistically, if you can't achieve success with that promise within 5 years, you're probably not going to make that one, unless it's something that can easily be forgotten. Yes? It's a large capital expense. So Wesley's contribution was to this. If you spend this large capital expense, so for example, my argument with respect to lap colon became, I can send you home on average in 2.1 days. The quickest send home, I did a day case sigmoid colectomy already. I did, man was fit. It was pretty easy. I did it. I sent him home the same day, brought him back for review the following day. Literally, man spent lap chole time in hospital, right? Who cares? Well, I care. Y'all think it's interesting, yeah? We are all in the medical fraternity. But in truth, the hospital is still running for 24 hours a day, 7 days a week with the same nursing complement. So realistically, the government may or may not care. Bed occupancy drives a little bit of care. So in Barbados, we have issues with bed occupancy. So with that, no, that becomes interesting to the point where, they try to push people out of the hospital. But does that still allow them to say, hey, I want to spend a couple $100,000 on a laparoscopic stack? Do I want to spend a couple $1 million on a robot? Yes? No. Not when I am cutting the nurses overtime. Yes? Community. So, community works. So literally on this film, on this image here, the slide, we have in the middle of that, we have the two of the former junior research fellows along with the health promotion nurse for the colon cancer initiative in the center. One is former, one is upcoming, I should probably say, in terms of research fellows. They're in different locations. They tend to go out. That's their little desk setup. They go out and they speak to the community about colon cancer screening, fit testing, etc. In the bottom right, we have the conference set up, and we had involvement of now Massey Foundation and so forth to help fund. They bought us a colonoscope. Literally, we got to thank them for that, and some other entities have also contributed. Sagicor as well, big contributors, because in reality, we were able to show the insurance company. Well, I don't know if we showed them anything, because I'm sure they probably could have read that on the internet. That screening was of benefit. But what happened was, by going out and doing these talks, we got the persons in HR and the persons in the employees and so ordinary people to ask, why is the insurance not covering the screening? Yes, and that lobby made the insurance start to cover the screening and made the insurance start to get involved. So we did this walk and run and all that kind of stuff to kind of create an environment where people are asking the right questions, because community support drives political change. Politics is the art of making the public love you. Yes? So at the point where the public is asking difficult questions and you don't have an answer, the political solution will be come up with some kind of answer, right? And literally, they could say, hey, I'm going to buy a robot because $1 million is not beyond the budget of the government, right? If there is enough political lobby in that particular situation, enough public support, private sector support also becomes key, because yet again, if your end user, the public, is asking, hey, why are you not doing this, and you don't have a good answer, you pretty much are forced into the position where you have to either offer it or come up with a good answer. Yeah. And it creates resilience. Why resilience? So in difficult times, yeah, you have to have the public on board in supporting whatever initiative or investment you're asking them to make, because at that point in time, you have group support, group cohesion. And I say this because yet again, I heard Sister, when Nottage was talking about the lab setup and so forth, Sister was shaking her head that that's the opinion. So imagine, I'll take your mind back to 15 years ago, right? So I'll go back further. When I was an SR at Cornwall Regional in Jamaica, I had my little lap things. I had done this thing in the UK. I came back and I wanted to do a lap appendix though. Literally no one else was doing lap appendixes. And people were losing it. They were losing it. What were you doing? How long is this going to take? I remember coming back. When I returned to Barbados, it was strictly private. And I remember coming back with a list. My first list at the private hospital was 3 lap choles and an achalasia. Now, at the time, I wouldn't want to say how long it was taking persons in that environment to do a lap chole, but they were like, this is impossible. This is an impossible list. I said, well, I'm going to start at 8. I'm going to finish by 3. No, it's impossible. It can be done. I started at 8, finish at 3. Yeah? 3 lap choles and an achalasia. And the scenario was because at the time I carried with a team. I believe it's hard not to go with a team. So I literally had brought up my nurse to Canada, had her trained in the environment and the equipment. We came to the theater together. I had the equipment and we were able to move along kind of seamlessly. So resilience is created. Now I use the public here. I included nursing within that public, or the hospital, or colleagues within that public, because by getting the public on board, you create resilience. Now, this one is for Lucas. Lucas was talking about the public-private partnerships. Been there, done that. Yes? So what we did, I am not certain what the recipe for. I'm not certain. What we did is we mobilized spray equipment. So at the time when I bought this start, I was able to negotiate demo equipment as a backup, because I said to them, I bought it in Canada. I said to them, I'm coming down here. I need to get some access to support if the equipment falls down. I don't want to be down. So I was able to negotiate that. At that point in time, I was then able to use some of the spares in a stack at the public hospital. Now, what you see here, this metal thing here, that was a cart that got made, and I got it made so I can lock it. Yeah, that's literally because things get feet, yes, or they get damaged. So at that point in time, I got this custom install. I put my little things on it, and I came and I started doing lap colons and same hellers and all that stuff in the public environment simultaneously. Well, as the private environment, because as I said, I spent about 2.5 years strictly private before they brought me into the public. That's a long story for a different time. So we mobilized this instrumentation, and I deemed it unsustainable within 10 months. Yes, that did not work. It did not work because I started to lose equipment. I said, stacks, I have things there. Next thing you know, I don't have instruments. In fact, literally 2 weeks ago, they were searching somewhere in the theater. They had a inventory, and they found a device that I lost so long ago that I can't even claim it's mine, but I know it, I recognize it. It's been lost for literally about 6-7 years. Yes. So at that point in time, I had deemed that unsustainable, right? But what it did do is it proved concept. So one of the benefit there, I think, was that it allowed people to understand that it can be done. Yeah. So if something has never been done, as Nelson Mandela says, it's always impossible until it is done. At the point where it is done, it becomes a part of the ethos, yes, of the environment. I also think that we worked a slightly different angle with the public-private partnership, and that relates to instrument reprocessing. And that's a taboo topic that I'm gonna deal with coming on to the end. The academic base. Now, I put these two shots in here because these two shots are fake it till you make it. Literally, when we were thinking of the Caribbean Colon Cancer Initiative in 2021, this is Courtney Chase. She's currently at Howard. I think she's in her second or third year. She was a junior research fellow. And that's Alex Doyle. He was a senior research fellow. Literally, I gave the two positions, I gave them titles. I say, yeah, here, but run it. Yeah. At the time, there was no funding in it. He was at the time looking to try to get into fellowship. Since then, he has done a diploma in surgical leadership at Harvard and 2 fellowships at MSK in surgical oncology. But we literally drew something on the board. So if you look on that far one there is actually a one of the normal distribution curves, yes? And we were talking on a little whiteboard. We put it up on the wall and pretended that we were looking at it. We created these shots that became the basis of the website, which ultimately now evolved into a proper research collaboration. The foundation people, so the buy-in, the early adopters, yes? Early adopters. So outside of the 3 people that we introduced earlier, we have 2 Bahamians in this crew. And I'm going to say something. It's a keynote address. I got half over so I could actually talk a little bit. Bahamas is one of the countries in the Caribbean I think people sleep on. And I think people sleep on the Bahamas in terms of, and I'm talking about the South and the Eastern Caribbean, because the concept is that the Bahamas is kind of more closely allied to the US than it is to the English-speaking Caribbean. But I think this is patently false. And I think it is patently false because if you look at it, every year Bahamas sends the best that they have to Carifta. Yes? And I use Carifta as an example. Jamaica stopped doing that until the Carifta Games was held in Falmouth in Jamaica. And they had I was living in Jamaica at the time. And if you all know anything about Jamaica and track and field, it's really like a religion. Yes? And there was a girl, I don't remember her name. She was maybe the captain of the Bahamian team, and they interviewed her. And she says, we come here to collect. Yeah? And so Jamaica had sent their B-side, right? As they had started to do. And Bahamas cleaned them up in Falmouth. Yes? They came to collect. And I say this because I watch what is happening in the Bahamas over the years coming here. And I can say that you're really doing 2 things. Pushing the envelope further and bringing, let's say, the rest of the Caribbean along with you. And that is very important. So Shanetta Johnson and Wesley Francis, 2 of the key fundamental supporters of the Colon Cancer Initiative at its origin and research collaborators. We got Professor Shamir Kowich, yes? And then this couple of years ago, that was our current junior research fellow at the time. And those was a group that began doing a lot of this academic work that formed the basis of what we were able to achieve. Our collaborators know. And I put them in size order because I got autism. Yes? And also to prove a point. I am UWI alumni. I'm associate lecturer at UWI Cave Hill, and UWI Cave Hill features in the far right corner in one of the small pictures. Who has been partnering us most significantly is Ross University, and big up to Ross. But Ross seems to be very serious in terms of their contribution in the region. I think UWI, at least Cave Hill, seems to have decided it's going to rest on its laurels. Yes? I've noticed that yet again, I don't even know if the campus in Bahamas is a full-on campus or if it's still an affiliate. I'm not certain of the rules of UWI. I'm not involved with UWI that way. I just come out here to do exams. But in reality, I know that y'all are really, yet again, putting in a lot of work. And I see it. I see it over the years, yeah? Again, there's another offshore university that's been helping us with funding. And realistically, Dalhousie, I put them over there, but I gave them 2 slots. One, because they help us with the actual performance of the task. We've got residents up to do training and so in Dalhousie, and they're very interested. They've sent residents down to do electives with us, and we've been having a very good exchange with them in the operative clinical sense. And also, they have supported some of the works that we're doing, and in the academic sense, we are burgeoning that relationship as well. Yeah, and as usual, the 2 Dalhousie guys, the Nigerian Prof. Alatishe actually wrote one of the seminal works on fit first testing in developing world. It's published in the Lancet, and he has been, and this African Research Group for Oncology has been a very close collaborator because we are very interested in these genetic links across the Atlantic. Regional collaborators, yet again, that's a must. College of Surgeons, cases, and I put UWI in general now in a much more prominent place because in reality, UWI has been the backbone of regional research. We must advocate green. So I'm going to be a little controversial here. There are 3 topics there, a little controversial. The first is instrument reprocessing. Now, each of these items are packaged. If you look on the lab stuff, each of them are packaged with a 2 with a line through it and a circle, meaning single use only. Single use only. I think that enough of us here have had to do some element of reprocessing to know that single use can be dual, triple, or sometimes quadruple use. I see y'all are sponsored by Medtronic, and I'm going to give you a hint. The Endo GIA, you could EO that ad infinitum. Yeah. Yeah. That might not be something you want to say on the open air, but as I said, this is the era of power politics, and we are not the possessors of power. So we at least have to be the possessors of innovation. And instrument reprocessing as a concept, I first heard about it with lab stuff coming out of the Dominican Republic. So this is maybe a decade ago. I was at a meeting in Puerto Rico where there was Spanish-speaking people and English-speaking Caribbean people all in the same environment. And the Dom rep, who I think by far have outstripped everybody in terms of lab volume, they were reprocessing the harmonics at the time. Because harmonics, roughly, in my jurisdiction, cost around $1,500 US each, at least. Yes? So at that point, I can say once you don't get any water in the bath, you're going to get a good few uses. I probably would say maybe 3-4 uses on your harmonic once you clean it, high level cleaning and EO. Subsequently, the ports as well. The ports, you get about 3-4 uses before they fail. Unfortunately, I tend to use the Ethicon port, the optically guided one. I can say that fails in about 3-4 uses. I don't know much about the Medtronic port systems. This is something we need to discuss. This is something we need to formalize because literally, and yet again, I know there's a concept with respect to greening of theaters. There's a push with SAGES in terms of the sustainability of theater. And Shanetta and I are hoping to work together towards some kind of study in this regard. We're looking at surgical waste and the amount of surgical waste that comes out of the theaters in a resource poor setting like ours compared to what comes out of the theaters in their setting. We're also looking at outcomes and we're looking at the sterility of the items and so forth. So these are stuff that we are looking to get towards as we go forward. It was a bit of a struggle. I see sister shook her head on the reprocessing. I'm telling you, the sterility police are coming around. Yes. So at that point in time, it is a must because I think in our environments we cannot afford to be buying these things um, after single use. And even then, in small island developing states, where are we gonna throw this stuff? Where are we gonna put these plastics? Where are they gonna go in the landfill if we were using all this stuff for single use? So I get on to two interesting other topics. Biodegradable plastics. I'm very interested in that particular scenario. I am literally gonna reach out to somebody about it. There's a on the other side I'm gonna discuss that. But biodegradable plastics is very important to see where we can go with that. And reusables where possible. When I say that, what I mean, so the metal chokers sound like a good idea. Yes? Until you have to suture with one. So why I say this is with lap skills, if you're doing a lap collie, for example, we can put the reducer and so forth. You can probably put in things. You can easily exchange instruments down one of those. You have the reducer from 10 to 5. You're good to go. You can take it off for the 10, put it down for the 5 instruments. But if something happens and you have to suture, how do you do it? I haven't figured that out yet. Because if you put the 5 instrument down the 10 port, and that's the only way you're going to get the needle in there, yes, you lose your pneumo. And that's very dangerous. You lose your pneumo with a sharp on the interior with no plan. How are you going to get that out? How are you going to transfer the instrument, the needle? So in my mind, it has become a situation where use them where possible. So for example, most 5mm ports can be metal ports. That's not a problem. The 10s, I think, almost always going to have to be a plastic port. Yeah. And so they have to be a little wise with how you're going to use your reusable devices. And yet again, I don't advocate for any of the fixed devices. So for example, the Marylands or anything like that, I think all of those should be reusable metal devices up front. I am against the use of plastics in that environment. So what are the possible future collaborations? So Striker Sustainability Solutions. Striker Sustainability Solutions is offered in the US and Canada. And pretty much all they do is reprocess. That's all it is. Yes? I think they got that model out of DomRep. They say, hey, this is a good idea. And they went with it. And so literally the problem with them is you have to be one of the hospitals that belong to their group because they have to take the items from you, reprocess the items, check the items, return the items. Yes, this is the system. So it has to be a closed loop system. So it's not going to be a situation where logistically it's possible for us as scattered small island developing states to be able to join Striker Sustainability Solutions. It's not possible. However, the concept in my mind, so yet again, having traveled around a bit, the major push right now is to get laparoscopic surgery or robotics into Africa because that's roughly 1.3, 1.4 billion people. The cost of the devices, however, is so expensive that it's not something that you can easily do. So literally SAGES and those have set up camps and things for training in Rwanda and other environments where they bring people from all across Africa to train in laparoscopy to go back home and just wish they could do it. I know people who are going to India and so getting certain training, come back, boy, they wishing they could do it. No. The problem is, if you are able to get this price point down, yes, or the solution be, how could you get the price point down? And that, yet again, is born out of, can you create a reprocessing system that is transferable? So you pretty much have a unit that allows it to move from or be housed on various environments where if you stick to the code, you could literally get this done. And I think this is something that is opening up as a discussion point going forward. This higher plastics guy, this guy used water hyacinths, invasive plant species. You pretty much, if you have any standing water, brackish or fresh water in Bahamas, I'm sure there are water hyacinths on it. And they're using this to create plastics that are biodegradable. This is a very interesting collab because in truth, if you're able to get these guys to create the plastics that then are able to create the chokers, then you have solved one of the major issues with respect to plastics in the environment or greening of the operating theater. The question is, can you do it at a reasonable cost? And that is the scenario. So even Ethicon, they're looking at their packaging and creating more sustainable packaging. But I'm sure they really want to get into how can we make these devices cheaper and how can we safely reprocess some of these devices. So after all that long talk, I pretty much gonna say the road is long and the battle is sure. And I have more questions than answers. I literally have not given one solution in this entire talk, right? And the journey continues for y'all youngsters as you come forward as to how you're gonna go. I hope that I have outlined a blueprint that you could possibly try to use. Yes, I'm hoping that there's something that y'all triggers the ears of persons listening here. Yeah, it must be done because, as we know, and I didn't get into all of the things because Nottage discussed them earlier. The fact that lap surgery is more cost efficient, is faster to get people out of hospital. It is cheaper in the long run. Yes, they're amortizing the cost. All of those things. We don't need to remake the wheel on the benefits of lap versus any kind of minimally invasive surgery. It is basically doing the same surgery, less disruption of the physiology of the patient. So pretty much, you know what I mean? It's better. It's better outcome. And so anything that's more cost effective in the long term is more beneficial to countries with economic constraints. Yes? The affordability at the upfront is the problem. How do you afford it in the beginning? Yeah? So once you can afford it at the beginning, then you can really now go towards the reaping the benefits in the long term. And this is really where I think that my colleagues, my little brothers need to be brothers and sisters. Sorry, no disrespect to the ladies involved here. Yeah. But so my brethren, that's the better term. Yes. So for my younger brethren, in this particular scenario, I think it is necessary that you address your minds to. No longer is it beneficial, of course. No longer can it be done, of course. The question is, how can it be sustainably done? How can we put the infrastructure in place that allows it to be sustainable going forward? So, I am literally a Muslim quoting the Bible here. Yes? I have written to you, young people, because you are strong. Yes? I am now getting old. My wrist hurt me. My shoulder hurts me. I am looking for the door. I'm looking to join those who are in the pasture. Yes? I thank you for the opportunity to have this talk.
Okay. Thank you so much, Dr. Griffith, for what an engaging, informative keynote speech. I took a few points from there. I think you've certainly planted the seeds of radical thought. You emphasized collaborative effort and the importance of resilience in forward movement. I did see a hint of the importance and power of women in advocacy. So I thank you. And as we sit here and listen to the lecture, I'm sure we're thinking, well, how can I be an advocate? Me as an individual, me as a surgical resident. And I think it's really, we know about informed consent, but we have to push informed intent, right? If you have informed intent, you speak to your patients in a different way and grow in them another advocate. You speak to your colleagues in a different way and your accompanying staff like the nurses and the surgical techs and grow advocacy in them. So let's move forward with informed intent based on what Dr. Griffith has told us. So coming up next, I have another little link. Dr. Griffith, I thought that was so interesting with the bleach in the water, creating light in a dark space. And coming up next, we have Dr. Francis, who will be speaking about ICG, surgery in the Bahamas and the Caribbean context, and lighting in dark places. ICG, or literally IC green, if you're a junior physician. And you're in a surgery with ICG, you're very fascinated the first time you see the bile duct light up green. So Dr. Francis is a surgical oncologist with 15 years experience as a consultant surgeon at the Princess Margaret Hospital and Doctors Hospital. He's a fellow of the American College of Surgeons and a fellow of the American College of Healthcare Executives. Again, pushing us forward in multiple spaces. Dr. Francis obtained his medical degree from the University of the West Indies and completed his surgical residency at Wayne State University in Detroit, Michigan. He obtained an SSO-approved fellowship from Tom Baker Cancer Center in Calgary, Alberta, and his field of specialty is breast, colon, liver, pancreas, and most aspects of general surgery. Dr. Francis also holds an MBA in Health Sector Management and Policy at the University of Miami in Coral Gables. I don't have to really introduce Dr. Francis to you, and I'm sure he's was hoping I wasn't going to read his bio, but come on down, Dr. Francis. You're welcome.
Thank you, Dr. Nottage, for that warm introduction. I just want to say that I work for Dr. Lucas. I am not paid with monetary anything, but with gratitude. And also I stand proud because, you know, Lucas has taken this on and will continue to take it on, and I'm happy to be a part of it. It all starts somewhere and it'll continue. So Lucas only gave me 15 minutes. He didn't give me half hour like Sally. So I guarantee I won't be here so long. But I've narrowed this down to the ICG fluorescence guided surgery, the Bahamas experience. I mean, it's kind of wide to say the Bahamas experience, but it's kind of maybe my experience. But I just want to share the journey of ICG in the Bahamas. I don't have any disclosures other than the fact that I work for Lucas. So indocyanine green actually first came about, they developed it with Kodak. You know, Kodak is now actually long bankrupt and gone. But in 1955, and the FDA first approved it in 1959. There's no known metabolites, basically, but you know, it's in that, if you look at the wavelengths of light, it's in that area that we can't see. So it's not visible to the human eye. The key features is that if you give it intravenously, it's well tolerated. It has a very excellent safety profile. It's cleared exclusively through the liver. So it's basically, when you give it, goes into the liver. And if it's cleared in the liver, it is excreted in the bile duct. And its half-life is 3 to 4 minutes. It's rapidly bound to plasma. And it basically undergoes no significant extrahepatic or enterohepatic circulation. So it's really an ideal substance to outline the liver and outline the biliary tree. So what's the process? Well, we inject the ICG. It binds the plasma proteins and it quickly circulates. And then you could use the fluorescence. Can be imaged. If you use a fluorescence guided camera, you can actually see it. And I'll show that to you in a second. And again, it's removed by the liver. So obviously it lights up the liver and it's eliminated in bile. So what does it do? Fluorescent cholangiography is real time. It's intraoperative visualization. As I mentioned before, it's only seen in the infrared spectrum. So if you have a near infrared light or camera, you can actually show the fluorescence. So it can be performed, as I said, in real time. There's no additional equipment required. For example, an intraoperative cholangiogram, we require additional equipment. But with this, if you have the agent and you have the camera, then that's all is needed. And it allows clear identification of the extrahepatic biliary tree. So this was initially introduced in September, actually. I would say, I could say that the first case was done in September 2025, just last year. And since then, I've been routinely performing it on all laparoscopic cholecystectomies in Doctor's Hospital. We give a small dose of it. I got to admit, full disclosure, when we first started, we didn't get the dosage right. And everything turned green. But over time, I think after the second case, we then realized that we had to dilute it a lot more, and then it worked. So in terms of methodology, it's a standard 4-port technique for lab chole we performed. And then during the dissection of Kalo's triangle, we use a 30-degree scope. Most of the people who trained with me know that I always used to use a 0-degree scope, but I transitioned to the 30-degree scope. It has a near infrared light source. The tower that is at Doctors Hospital and also in Princess Margaret Hospital is called a Vectron Tower. And it was used to visualize the bile duct anatomy. And as you're creating the critical view of safety, which I'll describe in a second. So during the dissection of Kalo's triangle, the ICG cholangiography was used to visualize basically the bile duct in real time. And the aim was, you got to identify the cystic duct gallbladder junction, the common bile duct, and the common hepatic duct. And essentially that's what we did. This is the tower. If you go in, and I think you'd be using this because it's going to be demonstrated over the next course of the day. This is a Vectron tower, the imaging navigation system, and it's important in fluorescence guided surgery. It can be used in it has multiple applications, but what we did, we primarily use it for the gallbladder and cholecystectomy. So we collected the data from September 2025 to present, and we looked at patient characteristics, operative duration, visualization of the bile duct anatomy, ability to achieve the critical view of safety, how often we completed the cholecystectomy, intraoperative blood loss, post-op complications such as bile leak or any bile duct injury. And, I like SPSS. And so I took a spreadsheet and then we put it into SPSS and basically give us our results. So again, as I mentioned, from September 2025 to this month, all cases, these were done at Doctors Hospital. They were done by myself. We actually had 14 consecutive cases, but only 13 was performed with ICG. That's because the anesthesiologist forgot to inject the ICG. And I'm there turning on the light and then says, "Where's the thing?" And he says, "Oh, he forgot." So majority of them were emergent cases. And I defined that as being done within 24 hours. So all of these were particularly emergencies. There were only 2 elective cases. So when we look at patient characteristics, again, so we only have the 13. I don't know if this projects very well, but I don't see it here. So you guys seen it? Okay. So obviously there was 70% females, right? Is that up there? Okay. I don't know. This is not projecting very well for me. Yeah. Oh, okay. I see. Something happened here with the block. Well, there was 70% females, right? And like I said, 13 cases, 70% were females. I also looked at BMI, but when I looked at BMI, I thought, boy, I just putting a number up there would not bring the point across. So I looked at the different classes of obesity, and I not like reporting this, but there was nobody in the normal class, right? Everybody was, so class 1, we had a 38%. And actually, I wish, I don't know if you guys can see it, but in class 2, the majority of people were in class 2 obesity. And that's a BMI above 35, between 36 and 40. And again, we even had some super obese people that we did these cases on, and that obese classes, it was 23.1%. The next category was ASA, and you can see again the dark. I don't know if it comes up very well, but the majority of them were high risk people. So ASA 3, So you can see that a lot of these patients, again, they were emergent, obese, and high risk from an anesthesia component perspective. And it was 53.8% of them were ASA 3 class. The next is basically the indication. The majority, 85% of cases were acute cholecystitis, and only 15% was symptomatic cholelithiasis. And I don't have it here, but if you subcategorize the acute coli, the majority of them were moderate to severe. Again, it doesn't show the way. I can't blame the IT for this one. But operative time was 94 minutes, basically. And the range went from 55 to 140. And, that correlates to how difficult the procedure was. Certainly the morbidly obese patients who had a severe acute cholecystitis, their procedures took much longer. The method of cholecystectomy I have here, it's supposed to read complete versus or partial. We were able to complete all of them. So it's 100% complete cholecystectomy. We did no subtotal cholecystectomies. And in terms of intraoperative complications, there were none. And there were no post-op complications. There was no bile duct injury. And it's hard to see. I wish I had my other thing, because the majority of the patients actually went home on post-op day 1. We did put drains in. And it's interesting. The patients who had drains, again, were heavily obese people, patients, and those with advanced or severe cholecystectomies. It was 23.1%. And it kind of correlated with those are the people who stayed until post-op day 2. Next, when we look at biliary anatomy, again, and I put this picture up. I wanted to embed a video, but I couldn't get it to work. But you can see here, if I have a pointer, can you see the pointer? No? Yeah? It's there? Well, you can see and this is when you shine the light. This is I did something wrong. I touched something. Oh, here's the common bile duct. Here's common hepatic duct. Here's Ruvier sulcus. I'm not going to ask anybody what goes through there, but some of my DM1 candidates should know what goes through there. But that's the Ruvier sulcus. This is the cystic duct. It's the gallbladder. This is what you consider the critical view of safety. You see the cystic plate is there, about a third going up the gallbladder. You see 2 structures going into the gallbladder here. This is the cystic duct. This is cystic artery. Very classic presentation. And the picture speaks, volumes. So we were able to identify the cystic duct using ICG 100% of the times. We were able to identify the cystic duct, common bile duct junction 100% of the times. The common bile duct, we only identified it 93% of the times. And then the common hepatic duct, we only identified it about 70% of the times. So you can see how, on the picture, how clear it can be. So what are my thoughts on the data that, again, is a small series, only 13 patients. But these are my thoughts. Well, first thing is we do have a lot of big patients. And I think that the majority females. Acute cholecystitis is the most common indication, surgery in this group. Emergency cholecystectomies do take time. Patience is a virtue. I think you got to take your time and do this. This is not I think a gallbladder, if anybody brags I can do a gallbladder in 20 minutes, 10 minutes and stuff, they don't really understand surgery. I think you take your time with this. The critical view of safety can be achieved in the majority of cases, and in this small series, we were able to do it in 100% of cases. Well, what I learned is drains increase length of stay. Kind of intuitive there. You put a drain in, is more than likely it's more complicated case, and so they tend to stay longer. The majority of people, all those who didn't have drain, went home on post-op day 1. And I say ICG is a nice adjunct, and it's an adjunct. It's not something that you have to rely totally on. I want to add a little on common bile duct injuries. It's still the most feared complication of cholecystectomy. And I believe that this is why we have to respect the common bile duct, because we only have one common bile duct. And if you injure it, then you basically, that patient has morbidity for life. And so this is why it's important for us to appreciate and understand not only the anatomy, but anything that can help us to delineate it. So common bile duct injury mainly is due to poor intraoperative visualization. And is either some misperception. You thought you saw what you thought you did. You thought it was a cystic duct, but it was really the common bile duct. Or misidentification. You just totally got lost, because when you have severe acute cholecystitis and you have what they call biliary inflammatory effusion and everything is stuck down, sometimes you can't see and you don't even know where you are. So a long time ago, the culture of safety in cholecystectomy was introduced. It's called COSIC, and it discusses the Strasberg's critical view, which we talked already. And again, you can see it's the same picture I had before, the Strasberg critical view. And again, for our DM residents, 1/3 of the duct. I mean, I could have gone up a little further, but you can see the cystic plate, the fibrofatty tissue between the gallbladder or the cystic duct and the common hepatic duct here is cleared, and there's only 2 structures going into the gallbladder, and that's the cystic duct here and the cystic artery. That's the classic description of the Strasberg critical view. And then the Rouvier's sulcus, you should identify that. The Rouvier's sulcus is down here. Cystic duct, you should always be above there. If you find yourself here clipping something, you're probably clipping the common bile duct. And so these are important little things that you have to pay attention to. And then intraoperative cholangiogram, which was this pretty much standard of care, but now fluorescence cholangiography, I believe, will start replacing intraoperative cholangiogram. And again, always recognize the principle. What is the principal target in laparoscopic cholecystectomy? Even though we talked about identifying the common bile duct, we talked about identifying the common hepatic duct, you don't need to do that. The principal target in a laparoscopic cholecystectomy is identifying the common bile duct cystic duct junction, which is here. You just need to identify that. You don't even need to see this. I mean, we like to see it, but if you're not seeing it and you're just here and that's where you put your clips, then you're safe. So those are my thoughts about, because the thing that we have to do with cholecystectomy, trust me, it's an easy procedure, but it can get real complicated, is to just stick and adhere to principles. Meticulous dissection, avoid a lot of blood loss, because if you notice, well, there was there was an EBL. You guys didn't see it, but I try to keep the field dry. Okay. So in conclusion, I told y'all I wouldn't speak as long as Sally did. But fluorescent cholangiography was successfully implemented. We did it in Doctor's Hospital. I think it's becoming the standard of care, routine. I certainly use it routine. I often see myself as a trendsetter. And so I hope that others would continue to follow and do that. Again, it consistently delineates the biliary anatomy. You can see I've showed it to you. In this little small series, there were no common bile duct injuries. Why? Because there was no misperception. There was no misidentification. We were able to see the cystic duct, the common bile duct, and the common hepatic duct. But more importantly, we were able to appreciate 100% of the time the cystic duct and the the cystic duct gallbladder junction. It's easy to use. Again, it's an adjunct. What's important is the culture of safety in cholecystectomy. So, fluorescence cholangiography with ICG, I believe it may be considered a standard when performing laparoscopic cholecystectomies. Again, it's a small series. I'd like to put it out there to our residents or whomever. Let's make it bigger. It's just 13 cases. We do a lot of gallbladders. We have the tower here in PMH also. I got the database. It's all there. Anyone can get it from me, and we can start adding cases to it. In Barbados in 2027, I think it'll be the 25th anniversary of CCOS. If we put all of those information in that database, we can have an excellent presentation. So I put that challenge out to you guys. Thank you. I could entertain any questions.
I'll make it even shorter. What do you do when your timing or logistics in terms of administration of the ICG has failed or passed? And what are your thoughts on redosing in those situations?
That's a good question. It actually lasts longer than we think, right? Because remember, it's excreted into the bile duct. And I think I read you can even do this up to 24 hours. So you actually can still see some, especially if you do it too early, it's a problem. But doing it later, you still can see some green. For cholecystectomies, I've not redosed. I know that people do redose, for example, for parathyroids because it uptakes so quickly and it washes out quickly, and also for colon cases. But I've not had to do it for gallbladder cases. But I'm glad you guys did it. It's easy to do. Yes, add it to the database. Any other questions? Okay.
Yes. Thank you, Dr. Francis, for your introduction to ICG in the Bahamas and laying the groundwork that you have done through your surgical enterprise and training all of us to do it. And we will see some ICG surgeries, I think live surgeries tomorrow. So those of you who've never seen it before, we invite you to attend. So from radical thought to trendsetter, and we're going back to Dr. Griffith, who will be presenting on the Caribbean colorectal revolution, integrating endoscopy and minimally invasive surgery for superior outcomes. Welcome back, Dr. Griffith.
Thank you, Dr. Nottage. All right, good day, everybody. Good morning. I promise this is the last time. Yeah. All right. So, the my talk today is the Caribbean colorectal revolution, integrating endoscopy and MIS for superior outcomes. Disclosures. This time, I'm always gonna be. Oh no, we don't have it yet. Okay. I'm always gonna be representing the Caribbean Colon Cancer Initiative. Yeah. The foundation, as we mentioned before in the previous talk, I didn't know they would be so close together. Our foundational researchers involved Dr. Francis, Dr. Shanetta Johnson, myself, Dr. Doyle, Dr. Courtney Chase, Professor Shamir Kowich, all of whom we discussed earlier. A lot of our work is community based, and the reason why I'm going to have a little discussion here about community is that, in fact, I think the most superior way, or the way the endoscopy can most produce superior outcomes in colorectal cancer is early identification. Yes, early identification, simple colonoscopy. And I think it's necessary that we lobby the community towards encouraging screening. Yes, our research-based stuff, yet again, this particular group revolved around the cells and early identification of lesions. And in fact, yet again, as we discussed, it's a little strange that these two talks are so close together. So the issue is really training, because once you are doing more screening, you need to have capacity, and to build that capacity, you have to do training. And suffice it to say, there is no AI in team. It requires a team, yes, to get this thing done. And in the CCCI, our guiding mission is a robust screening program can lead to CRC prevention. Now, I'm going to be a little old for a minute here now again. And I'm going to talk about things that are not necessarily my business. So, when I first graduated medical school and as an intern, etc., cervical cancer was a major issue. Literally, you would find so many ladies presenting with advanced cervical cancer. Fast forward a number of years, and the introduction of more robust pap screening, pap smear screening, etc., it is rare now, at least in the jurisdictions that I work, to see ladies with advanced cervical cancer. What we are noticing is more persons going for colposcopy. And the reason being is that cervical cancer, like colon cancer, is a preventable illness. Yes? If you identify it early enough, you can intervene at a stage in which it is still benign to reduce or eliminate the disease in its entirety. Yes? And I think this is actually what needs to be done with colon cancer. We need to make it somewhat sexy. Yes? You joke about it, but think about prostate, for example. People always think about losing their virility as men, so they get their prostate cancer checks. Cervical and breast, yet again, that's part of women's sexuality. They do it. No one thinks about their colon, man. Yeah. So a path to implementation. First of all, fit first screening. I believe this is a must. Why? Especially in low resource setting, it is necessary for us to identify lesions early. And the easiest way to do it would be to do an annual fit. The cheapest way to do it, one would argue. Doing colonoscopy requires resources, it requires colonoscopists, etc. But if you're able to eliminate or reduce the number of people coming to colonoscopy by screening a wide set of the population with a test that is unlikely to be very complicated, yes, you are able to get a large portion of the population screened cheaply and effectively. Education and sensitization, that's an absolute must. As I said, make it sexy, make people interested in doing it. It is necessary to get that community buy-in and then to build the capacity via training. Now, this is our little experience with this. It has not been an easy road. From 2022 to 2025, I think this was 2026. We had distributed 1,500 fit kits, yes, over that time. Literally, the vast majority of persons did not return their fit kits. The attrition rate was something like 74%, almost 75%. In November last year, we distributed 50 kits to the members of the Barbados Sanitation Service, and pretty much I was told that after the talk, most of the guys threw them away because they said they were they didn't want to know. They said it's better to if you don't know it, don't even hurt you. Yes, not realizing that you will come to find out at some point in the future. The largest return, in fact, that test was interesting for the fact that we gave them to 5 public service groups: the sanitation workers, the legionnaires, that's guys from the military that had retired, the nurses association, fire, postal, and yeah, there was one more, the police. Yeah, so 6. The highest return was actually from the police. And it was because what had happened is that in the year prior, we had had 4 or 5 training sessions with the police and sensitization sessions with respect to colon cancer. And so the police returned about 60 to 70% of their kids. The next highest was nursing. Nursing only returned 30 something percent of their kids. Yes? So in reality, we realized that we have to increase the number of engagements because we assumed that nursing would be high because they literally work in the area. But no, they too, maybe like the sanitation workers, did not want to know. Yes? So of that, we had about 386 tests returned. About of those tests, the positivity rate was, I think, about 34.5% for females, 37.2% for males, and ultimately most of the persons around 50% of those that were positive did in fact have a polyp of some kind. CRC facts, right? So why I said it was not an easy road on the last test is that in our environment, in Barbados, Barbados has the 8th highest incidence of colon cancer in the world. Yes, it is the 3rd highest in PAHO. It is the 2nd worst survival. According to data that we have been doing, around 70% of the people are diagnosed as stage 3 or 4 disease. And according to the Barbados National Registry, about 65% of people are dead within 3 years of diagnosis. And that might be related to the fact that they are advanced disease at diagnosis. So yet again, this should not be an easy sell. This should not be a difficult sell, sorry. Yeah. But it still is. It is the 3rd leading cause of cancer-related mortality in Barbados. As we all know, things that we all are aware, colonoscopy is the gold standard for screening. However, when you identify these, what do you do? When you identify large polyps or advanced polyps, what do you do? Right? Because realistically, what was done before was remove the whole colon. Yeah, so, well, the whole meaning the side. So if it's a right-sided disease, right colon. If it's left-sided disease, left colon. If it's rectal disease, anterior resection. That was the standard of care for quite a number of years. And in fact, one would still argue that cells is emerging. Yes, it is still considered relatively the standard of care in most jurisdictions. So what is cells? Cells is a combined approach where you use endoscopy and laparoscopy to be able to remove large or advanced polyps. Pretty much, that's the whole scenario. There's 4 types of cells. There's basically laparoscopic assisted polypectomy. That's removing large polyps while looking at it directly from the outside to make sure you're not breaching the wall or coming close to the wall. It's full thickness laparoscopic excisions. That's where generally I use a stapler. We bring things up, we staple, make sure that at endoscopy you have encompassed the entire polyp and its base in the staple line. There's full thickness cells where you can cut through either from the top or the bottom and remove a section of colon and close it. And there's endoluminal surgical resections, EMR, etc., that involves the removal of the polyp, either full thickness with clips or large, very close to full thickness with suturing. Lap-assisted polypectomy. So there are 2 types that I do. I do the lap-assisted polypectomy and the full thickness excision. I am not so comfortable doing the full endoluminal or EMR. We don't have the resources or the equipment for it. And realistically, I am not trained to put endoluminal clips. And I think that if I'm going to be cutting out the whole top and suturing it from outside, I prefer the staple line. It's easier. Yeah. So lap-assisted polypectomy was first described in 1993. It's the 2nd most common technique used in our series, but the most widespread technique used in the world. It involves both a surgeon and an endoscopist working simultaneously. Now, when I started doing this, I was both the surgeon and the endoscopist. I would scrub, I would put in the ports, I would set up the dissection and set it up. either pass the scope prior to that, close to the environment, because I don't want to blow it up too much and I want to suck down. And I'm going to discuss why that's an issue, because as we go forward, and then I would run back to the bottom, scrub and do a bit and hold it in a position, get the anesthetist to hold the endoscopy in place. Yeah, and we'll be able to do our excisions that way. Or if it was resectable, I do the polypectomy inside and then return to look at the area on the outside. Generally, you have to use a bit of dye to tattoo the area so that you make sure that it is clean. There are a number of things when you go in there that you have to assess about the polyp. One, is it hard? Is there central ulceration? Does it look like a malignancy? Does it occupy more than 50% of the circumference? All of these are things that you have to think about before attempting to do a cells, because unfortunately, should any of those things be in place, it is probably not a candidate for a cells. At that point, you just proceed to do the laparoscopic colon resection. So the procedure itself, as I alluded to before, you can identify the polyp there. For those that don't know, the polyp is the thing that looks like a cauliflower. We inject some dye before to raise it up, and then we would remove it via with a snare. Generally, I'd use a hot snare. I think the movement is afoot to use cold snares. I have started using cold snares in recent times. The issue with the cold snare to me is bleeding, because one thing is to have a surface that looks good. Next thing is to have people bleeding for maybe 24 hours after. They're quite concerned by this. You got to monitor the serosal side, of course. You have to get the sutures out. This is why sometimes, not always, sometimes you have to get the suture out. This is why having advanced lap skills is beneficial in this particular environment. If you notice that I'm not going to show a video, I promise. If you notice that the surface starts to look a little thin or disturbed, at that point it's easy to put a couple of stitches and oversew it. And I think in this particular scenario, that's exactly what I was going to do there. Full thickness excisions, those are easier. Normally, it's associated with lesions around the appendiceal orifice. So in both of these cases, you have one actually in the appendiceal orifice, and you have one that, oh, this is projecting very horribly. It's one that's around this region here, but you're not able to see it very well. In the cecum, and you just do a cecectomy. Yeah, as you can see, basically a cecectomy. In this one here, the image on the right, we were very close. The projection on these images are really poor, I'm sorry. But this is the terminal ileum, that's the cecum. And so I have the endoscope in looking at it. So you can see the light from the endoscope. I'm looking at it to make sure that I'm not compromising the ileocecal junction. These are the two techniques I don't do. As I said, I don't have the equipment to do them. So they use either clips, yes, or in my mind, if you're going to take a full piece out of the colon, better you do it with a stapler, man, yeah? That's my preference. I am a little unhappy excising a thing with a harmonic, for example, the scissors or whatever, and then oversewing it. I think that would be unnecessarily problematic. I think I use sutures in some cases to allow me to get the lesion up into the stapler, but I don't really see the reason I have to excise it and suture it. So I'd use the sutures to lift it up so that I get a good fire. Not that I'm against the technique. If it rocks your boat, if it works for you, good for it. The benefits: it can be performed safely as an outpatient procedure. So literally you do these cells, you can send people home. Yeah. I initially started by keeping people overnight. I have been more now inclined to let you go home. I think it's lower complications than colon cancer resections. Yes. Simply because you're not removing any significant blood supply. It's more cost effective than a colonoscopic resection. Sorry, than a colectomy. And the reason being, yet again, you're using less staple fires, you're using less equipment. Pretty much it is a cost saving at that point, and it preserves bowel. So back in the day, we didn't think bowel was worthy of preservation. Ask a patient who has had a significant colon resection and is passing 2, 3, 4 times a day. So our series. So initially, this particular series was accepted by surgical endoscopy, but our numbers were down. At that time, we had 8. We started with 3, and then we went to 8. And now we're at 10. Pretty much this happened over the course of 6 years, so it wasn't like it was very fast. Yeah, because yet again, not everyone has the buy-in, so some people were going to get their colons removed. The patients, we basically compile a little database. The series, the patients are between the ages of 41 and 83. 90% of the cases were done by one person, that's myself, and the last of the 10 was done by Dr. Padmore. I think subsequent to that, we have a couple more that have not been entered. I think Dr. St. John has done one as well. So I think we're maybe at about 11 or 12. Most patients were referred from the GI with, let's say, what they consider complex benign polyps. Now, one of the other things that started to happen, which is probably one reason that our numbers haven't been advancing, is that we have started to get more aggressive with larger polyps at endoscopy. So literally, we wouldn't carry them for cells because we would take these big polyps at endoscopy itself. Whereas before, we were carrying them for cells. But as we get a little more comfortable with, okay, we're not going to really breach here, we've been doing more aggressive, larger polyps at endoscopy. In all cases, the benign histology was confirmed by the histology. Realistically, you do the biopsy before the biopsy says it's benign. It's either high grade, focal high grade, or sometimes low grade. They're just large polyps. So the concern is always, as for the residents to be aware, are there areas of invasion? Because once you have invasion, then you have to talk about SM levels. I don't know about the pathologists here, but I find the pathologists are not consistently reporting SM levels in our environment. Maybe because we don't find much early stage disease, right? But at the point where it is benign, you can pretty much proceed with this procedure here. 40% of the cases were done via laparoscopic cystic polypectomy. So in the original series, the first 8, I think our numbers, no, I'm sorry. Yeah. So initially, the first series, we were actually beginning with lap polypectomy. I don't remember where that number was. And lap polypectomy was the more common procedure. Flex has actually taken over lap polypectomy now, and roughly is a 60-40 split. One case had to be abandoned. And it was abandoned because we were trying too much. Meaning, this particular patient had a known cancer in the rectum. And we had to do a low anterior resection on him. However, he had an advanced adenoma in the ascending colon and another adenoma somewhere along the way. While we're doing this procedure, because we're using air, we're not using CO2, so that's another thing. So most of these procedures done internationally now are being done with CO2 insufflation. We're using air. So the CO2 absorbs much more quickly. When you use air, you can blow up that small bowel, and once you blow up that small bowel, your working space is short. So at that point, we pretty much had to abandon, the cells and end up doing a subtotal on him. It turned out that the lesion in the ascending colon was benign, and of course, yes, he had a malignancy in the rectum. So this is the series, pretty much, and a mixture of ages. What is beneficial here, though, is that there are around 6 of these cases. 6 or 7? 1, 2, 3, 4, 5, 6. 6 cases done for screening or surveillance. So ultimately, it does show the benefit yet again of screening in terms of allowing us to identify early disease and preserving colons and avoiding major resections and actually malignancy in and of itself. Because of note, all of those polyps were benign. They were either high grade adenomas or low grade. I think one of them was a serrated adenoma. Lessons learned so far. Thank God we've had no complications. We've had no recurrences noted in the series because yet again, they were all benign lesions. We learned we need CO2 insufflation. So we're trying to get a CO2 insufflator. I think it'll allow us to be far more aggressive with our cells plans. Future plans and aspirations. Wow, that's a big one. Train up enough people so that there's comfort with a significant set of the surgical population in the environment doing cells. 2, funding, getting the equipment. Yes, we need to get some equipment. We need to get some buy-in. However, if you're doing something twice a year, yeah, you're not gonna get much buy-in with a twice a year procedure. So the question would be getting buy-in from your colleagues, and this is a hard one because realistically, if you are making your money taking out colons, and I'm saying, hey, we can do this without removing the colon, yes, um, maybe you might not be so keen on that particular scenario, yes, and the next thing would be basically fostering similar procedures across the region because yet again to become significant in terms of our numbers it would be necessary for us to get a, a larger cohort of patients. Of note, it is easy when you're doing things that are on the cutting edge to say you're coming from a resource poor setting because nobody believes that you're going to be in Barbados doing cells when cells was being discussed just the other day at amongst major centers in the world. So at that point, that allows us some kind of advantage. But if we are at Barbados, Bahamas, Jamaica, Trinidad, with a series of 50 to 100 cells, at that point in time, you are far more significant in terms of your ability to generate interest and hence generate equipment. These are the references. I thank you very much. Yeah. Or one plug, if anybody wants to work or do stuff with the CCCI, please contact us. That goes to the admin team. They'll be very interested in help in the help. We want to increase the database.
Thank you again, Dr. Saleh, for that enlightening and engaging lecture. You were faster than last time. Yes, you were faster than Dr. Francis. Small gains, small gains. Please, and use the mic so that our Zoom people can hear.
Thank you again, Dr. Griffith, for the talk.
Thank you.
You touched on it a little bit, but I have kind of like a two-part question. What challenges have you had with training and funding, and what ideas or any novel ideas you had to have or to mitigate that, and probably some ideas you can give to us as well?
That's a difficult one. So the challenges with training and funding. All right. So a part of the issue with training persons to do endoscopy is initially one of the issues that we had was buy-in from the gastroenterology colleagues, and I'm going to be very controversial. But hey, I'm here. Let me be controversial. Gastroenterology was not very keen on having surgeons return to the environment and train their surgical junior colleagues in endoscopy. Now, that's a phenomenon that I guess has been back and forth with gastroenterology and surgeons over the last, I would say, maybe decade and a half. In Canada, I was trained in endoscopy predominantly by gastroenterologists, yes, but I was an MIS fellow. And each of the surgical trainees in the US and Canada has to go through a rotation in gastroenterology. Gastroenterology, this endoscopy is an important adjunct in the general surgical practice of any modern general surgeon. That's my view. However, you would find that what is happening in those environments is one, there's a workload that is above the gastroenterology department of itself, right? So there are enough patients to go around. Two, the gastroenterologists are going further and further with their skill sets. If you are in a smaller environment and you've limited yourself to screening for diagnostic purposes scoping for diagnostic purposes or screening with very little intervention, or even if you are doing some intervention but not a lot of intervention, then you are more wary of having surgeons step into that environment because money make the mayor run. Yes? At this point in time, you are then now looking at a scenario where, and there are a couple of things to be known here. There are studies looking at the acquisition of endoscopic skills by surgical trainees. In gastroenterologists take around 150 cases for proficiency. That is because a lot of their practice is, prior to that point, cerebral. They are internists. Yes? Surgeons have the hand-eye coordination that allows them to achieve the same level of competency via metrics. That's the 83% intubation on the cecum, etc., 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 in 50 procedures. Yes? So, you literally are training a group of people faster. Who, now, what is the worst thing that can happen if you were doing a colonoscopy? You could perforate, right? If you're a gastroenterologist and you perforate, what you got to do? Exactly. You're a surgeon, you perforate, what you do? Exactly. So you literally are arming the people who are more equipped to do this procedure than you. Yes, so let's call a spade a spade. I speaking to an audience that likely involves outside surgeons, inside surgeons, different types of surgeons. We keeping it 100 here. Yeah? At that point, you kind of have a resistance. So one of the things that happened in our environment was we had lobbied for a day for surgeons to be able to scope. And initially there was resistance to this. Then they had some retirements within the gastroenterology department. We got a foot in the door, and now I think the colorectal surgeon has a day that he scopes. Yes? Volume would then be the issue. So if you're going to train a resident, how are you going to achieve that volume? So you're going to have to say, well, okay, we're going to start to institute a rotation just as they do overseas, where that rotation is in gastroenterology. Are the gastroenterologists keen on letting you scope? They can let you pull out the scope, and you can get confident pulling out the scope. But then after some time, you got to start pushing in the scope too. Yes? I let you scope. You come and scope. I don't have a problem. But I don't have a scope there. Yes? Literally, I'm not dedicated to scoping in that same way. So it's how are we going to train you? I was not convinced of the models before. So recently, I've also identified a model that is really very good. So we actually, in the last training course, we did models, and we're trying to get these models sponsored by CCCI, well, sponsored for CCCI to be able to take this regionally, because yet again, PAHO in 2016 predicted there would be a 60% increase in colon cancer incidence in the Caribbean over the 10-year period that followed. We're in that 10th year. Yes, and I'm sure all of you see far more colon cancer than you were seeing a couple of years ago. So outside of personal issues with the gastroenterologist, or let's say collegiality issues with gastroenterologists, it is necessary that surgeons get these skills. So models. So we actually recently now have been able to identify models that work pretty well. But I don't know about the Bahamas. But yet again, in Barbados, we have only 1 or 2 scopes in a public hospital. So how are we going to do a training course that involves models? Yes? If you don't have the equipment to be able to spare to provide the models, for the work on the models. So yet again, this is where CCCI has been working with some lobbying to get some of the equipment that we had before. So public-private partnerships, maybe public philanthropic private partnerships. So Surgical Solutions, we changed out our stack a few years ago. So we actually have a stack and a older scope that we can use for that purpose. So one of the things is to try to create systems that allow us to move these models across the Caribbean at various junctures to allow the residents to be able to scope. You then have to be able to scope in theater, so you'd have to then know, see if the hospital would get the equipment. So it requires a lot of lobbying. And as I said, fundamentally, the core of this discussion, I think, evolves out of research. Because in researching, I was able to say, so the Barbados National Registry keeps cancer data. They do not keep colon cancer stage data. So if you want colon cancer stage data, you have to talk to the Caribbean Colon Cancer Initiative. So we break down, so we have a database, and it was born out of colon cancer resections of 300 plus colon cancer resections, that we were able to say, okay, this is what the stage data is, yeah, for our environment so far. And so it's hopefully evolving, and that's where I think earlier Brandon Griffiths, who's the current junior research fellow, was here a couple with Dr. Lucas a couple months ago, maybe a year now, where he was kind of helping get the database together so that we can now say, all right, I haven't analyzed the Bahamas database yet, but whatever is there, that this across these two countries, this was the incidence, these are the number of cases, these are the stages that they were at. At that point, you're making a logical argument that colonoscopy does in fact reduce cancer incidence while screening, right? Allows for colonoscopy, that allows for reduction in advanced stage disease. So at that point now, you're able to lobby both private partners and the government to be able to provide the equipment that you need to allow for training and execution of these procedures. And I think that's so it's a strategy that has to be evolved over time. And given that over the last 16 years I've been thinking about this, it means that you don't have to think about it. No, you can say, yeah, here, we got to do some research. We got to get this thing here, because that's where you need to go with that particular model, I think.
Thank you again, Dr. Griffith. Thank you, Dr. Wright, for your question. I think it was a very timely and pertinent question. And it sounds like the answer is using your research as a foundation or a platform to get public and private partnerships, because it sounds like CCCI is building capacity through their private partnerships with other, I don't know, like scope companies, etc., to train the public residents, right, at the public hospital. So I'm sure we can find others in the room who can do a model like that for us. Not looking at Dr. Lucas. So I think at this point, we really need to proceed with the program, but everyone's been sitting for a little bit. Dr. Verinda, if you'll give us 5 minutes, everybody stretch your legs, please, and come back. If you need a snack, get a snack. We do have a welcome video that I think it would be a good time if we could play that now. Dr. Halliday, do we have it loaded and ready to go? And while that is playing, can just get a quick stretch and then we'll move on with our program.
In surgical education in our region. We're also deeply grateful to our platinum sponsors, Ports International, in partnership with Medtronics, whose support has been instrumental in making this conference possible. We also thank Varencourt for their valued and stalwart contribution from the inception of this conference. Your presence here reflects a shared commitment to innovation and excellence. I encourage you all to ask hard questions, share experiences, and build connections that extend beyond this conference. Once again, welcome, and I wish you a productive and inspiring conference. Thank you. Greetings, distinguished colleagues, guests, and partners. It is my great pleasure to welcome you to the third annual Minimally Invasive Conference and Workshop right here in Nassau, the Bahamas. We are honored to have such a distinguished group of surgeons, trainees, and healthcare professionals gathered for what promises to be an engaging and impactful theme. Advocacy for minimally invasive surgery is both timely and necessary. It is our duty to advocate for wider access to approaches that improve patient outcomes and reduce the burden to our healthcare systems. We must advocate for minimally invasive surgery within our institutions and across our healthcare systems. Over the next 3 days, you will participate in hands-on workshops and meaningful discussions designed to strengthen both your expertise and your voice as advocates for progress. I would like to extend our appreciation to our host, the University of the West Indies, and the Department of Surgery at the Princess Margaret Hospital for their leadership and commitment to advancing surgical education in our region. We are also deeply grateful to our platinum sponsors, Ports International, in partnership with Medtronics, whose support has been instrumental in making this conference possible. We also thank Varencourt for their valued and stalwart contribution from the inception of this conference. Your presence here reflects a shared commitment to innovation and excellence. I encourage you all to ask hard questions, share experiences, and build connections that extend beyond this conference. Once again, welcome, and I wish you a productive and inspiring conference. Thank you. Greetings, distinguished colleagues, guests, and partners. It is my great pleasure to welcome you to the third annual Minimally Invasive Conference and Workshop right here in Nassau, the Bahamas. We are honored to have such a distinguished group of surgeons, trainees, and healthcare professionals gathered for what promises to be an engaging and impactful few days. This year's theme, Advocacy for Minimally Invasive Surgery, is both timely and necessary. It is our duty to advocate for wider access to approaches that improve patient outcomes and reduce the burden to our healthcare systems. We must advocate for minimally invasive surgery within our institutions and across our healthcare systems. Over the next 3 days, you will participate in hands-on workshops and meaningful discussions designed to strengthen both your expertise and your voice as advocates for progress. I would like to extend our appreciation to our host, the University of the West Indies, and the Department of Surgery at the Princess Margaret Hospital for their leadership and commitment to advancing surgical education in our region. We are also deeply grateful to our platinum sponsor,
Oh, it's on now, sorry. So just saying that we'll continue this day of conference with panel A session, gynecology and training. Our first speaker is Dr. Vrinda Sakakar, an obstetrician and gynecologist. With over 30 years of experience, she's been serving the Bahamian population for the last 25 years. She obtained her medical degree and postgraduate degrees from India and a public health degree from the United States. She's also obtained her bachelor's in minimally invasive surgery from the International Society for Gynecologic and Endoscopic Surgeons and a fellowship diploma in minimal access surgery from the World Association of Laparoscopic Surgeons. She's a lecturer of obstetrics and gynecology at the University of the West Indies School of Clinical Medicine and Research, a consultant here at the Princess Margaret Hospital, and the chair of the OBGYN services at Doctors Hospital. She's actively involved in research and postgraduate training at the UWI and presently serves as the university's examiner for DM obstetrics and gynecology. She's well published and presented at many national and international conferences, and her special interests include minimal access surgery, such as hysteroscopy and laparoscopy, and infertility. As an endoscopic surgeon who performs major gynecological laparoscopic surgeries like hysterectomy, myomectomy, and operative hysteroscopy, she is an active member of professional bodies like the American Association of Gynecological Laparoscopic Surgeons with special interest in hysteroscopy, World Association of Laparoscopic Surgeons, International Society of Gynecologic and Endoscopic Surgeons, Caribbean Association of Gynecological Endoscopic Surgeons, and American Association of Reproductive Medicine. So well-credentialed are Dr. Vrinda. She enjoys singing, traveling, reading, and connecting with people, and adventuring into many DIY projects. So we invite you now, Dr. Vrinda, to come and give us the first lecture in this panel, entitled Foundations of Excellence, Mastering Basic Laparoscopy for Every Surgeon. Dr. Vrinda.
All right. Good morning, everybody. And good morning. Hello. Hi. Good morning, everybody. And good morning, everybody who is joining us online. Thank you for that introduction, Krista. Yeah. Okay. My topic has changed just a little bit because we are in this particular conference. We are trying to be more as advocacy. So I have been uh, bestowed the responsibility of talk a little bit about the training for residents. So that's why my topic a little bit. I'm not talking so much of advances of laparoscopy or minimal endoscopic surgery in the region as such. We are talking more how can we, what are the options available for the resident training. Okay, so so why do we have to train the residents? I am not really going into detail why minimally invasive is best and all of those kind of things have already been discussed. This is the way to go forward. We cannot really be cutting people just left, right, and center. So, but then why is the structured training necessary? One, minimally invasive surgery, as we talk about, mostly laparoscopy, I will be concentrating on. I'm not concentrating on endoscopy or hysteroscopy at this time. These are the stick surgeries, and we have a 2D vision, and this is the extension of your hands, but really difficult. So it is a steep learning curve, and the mistakes can happen. This is the reason why you have to have structured training, and you have to have training. You can't really, when we do one-on-ones open surgery, you have your surgeon who is teaching you and you are assisting and you are learning one at a time. When you are doing a laparoscopy is a solo business. You are the writer and you are the one who do complication and you are the one who have to solve them. So that's why proper structured training is very important. That is the what you can call it as a patient safety. And second is most of the programs, postgraduate programs now, are their accreditation will depend upon if these programs provide a structured training to their residents for endoscopy. So that is the other reason why it is very necessary for in our DM program. When I say our DM is surgical branches, that means surgery and gynecology, we have to have structured competency training. Okay. So what are the core components? These are all of these things which are on the slide. You all know. You have to have knowledge, psychomotor skills, and then the technical part, depth perception, suturing, all the models and things. I'll go. All the hands-on doesn't only mean that is the training program. The training program should be developed in which incorporate all those three components which I wrote on the slide there. Okay. So what are the training pathways available for residents? When you are in a residency program, you know you're going to be there for 4 years and you will be in surgical training, helping your surgeons and doing your things, doing your on-call and on-call and all. But definitely you will have to get acquainted with the laparoscopic surgery. So the training pathways are either simulation based, box trainers, virtual reality, and the VR simulators now. When you go a little above, a level up, you will have cadaveric workshops. Then you will have live animal labs and mentored operating room experiences. These are like going upscale. So the first one would be actually the basic one. You would be the simulation based and basically understanding the operating in 3D while using a 2D imaging. So hand-eye coordination is the must. So this is a learned skill. So who are the organizations who offer these courses? Okay, so many organizations offer the courses. Especially the main one would be the American Association. For us, actually, in Caribbean and in North American hemisphere, you have the big association which is called AAGL, American Association of Laparoscopic Surgeons. And then you will have the American Association of Surgeons. So there are two main programs who actually offer structured program with certification. So this is the website of the AAGL, and if you see here, this is EMIGS, which is Essential of Minimal Invasive Gynecology. So these are the module-based program. So when these are all paid program. So when you pay the fee, and then you do the online written portion, and then there would be a lab, what you can say, the skill level, you will have to achieve certain skill level. These programs, then you have, so I have listed couple places where you could get these kind of courses. WALS is like World Association of Laparoscopic Surgeons. The big guy over here, all over in the internet, he is here, Dr. Mishra, and he has expanded himself to Dubai as well as to Orlando now, and he is conducting 2 courses in Orlando, and he have year-round courses going on in India. But WALS is not just Mishra. WALS is all different organizations, and these all organizations offer courses. Okay. The good thing about this age and our age is you have a variety of courses available to you. If you want to go and register, you don't really have to be in their residency program. You could go in conferences and do it too. I'll come down to what is the bottom line. Okay. Then you have the, as I was saying, American Association of Laparoscopic Surgeon. And if you see, this particular document has been sent by Dr. Lucas around to all the residents. And I hope some of you would have clicked onto the link, which has the modules, and each task is timed. I have a short little video how those tasks are, because it is eventually hand-eye coordination and depth perception. Okay, once you get comfortable, then you go ahead, and your basic surgical teaching or basic surgical learning doesn't change. That means if you have to incise the peritoneum in that manner, you have to have the knowledge of energy. You have to have knowledge of energy. That all come in your general surgery also. Okay, so the mainstay of these things, this surgery, these trainings would be on the goal given task. So you have to do certain thing in certain time. So you have the other in association, which is basically is a gynae association, and I am proud to say that we are part of it, which is ISGE, International Society of Gynecological Endoscopy. KJS, which is a Caribbean Association of Gynecological Endoscopy, is we could say a sister society. We had a few conferences, and at that time, actually, Dr. Charles and I, we gotten into the didactic and hand-eye coordination testing. It used to call LAST, and then I went one step further to get my bachelor's. So they offer the courses as well as certification. You have MIS also is from Europe. Then we talk about Strasbourg already, and this MIS basically more on gynecology, and they also offer certification. ARCAD is a big one, and you, even if you are a resident, please go on this site. Just go on this site, register. You can, and it is free. You don't have to pay any contribution to any subscription to that, and there are videos. And then if you want to go further ahead, then there are centers in Brazil, some centers in North America, I think one or two in India, and definitely there are centers in France. The pioneering, the person who started this ARCAD is in 1994, so it is there for quite long, and it is a combined one. It is gynecology as well as surgery courses, and they incorporate robotics also. And then others. Okay, so you have SAGES, you have almost all European countries, they have their all small things. You have KEL, you and they are British also. And then there are a big Asian and Indian societies. because remember we are talking about the population. So India and China is a leading actually. If you watch those, if you go on YouTube and type anything, all number one videos are coming from India and China. Okay, and I always say that we learn from the, what can say, the grace of good people. There are people who want to showcase, hey, I can do that, but yeah, we can learn from them, right? So restricting knowledge is a thing of past. The more you give, the more you learn. Okay, so I remember, as is actually Dalai Lama said, or one of them said, if you want to learn something, write a book. So if you want to learn something, make a video. This time, right? If you are not visible, when they say publish or perish, you have to be visible now. Okay, so yes, so I highlighted here UWI programs. Actually, I was partially in the meeting at this time, postgraduate meeting, and what is the, what do I have there? Okay. Oh, my slide didn't get in here. Okay. All right. So I have it as UWI program. So what happened is, we at this time, we do not really have a requirement of surgical as well as the gynae residents to have completed these programs. We don't. Okay. But if you see in other residency, in OBGYN residency in US as well as surgical residency, it is a prerequisite. Even if you are becoming a generalist, you have to have these courses done. And we just have to be working with, we have to be with the flow, because if we don't, we become obsolete. UWI will become obsolete if we don't really go along with the what is the trend. So the meeting, I forgot the name of, but you probably know. It's a surgeon from Jamaica. His name sounds more like a Chinese though, but he's Jamaican, I think, and he is an endoscopic surgeon. So he has developed a program which is a 10 weeks program. So 10 weeks didactic, and every Saturday would be hands-on. So the program, I think, is getting certified at this time, and once it is getting, it would be available to the surgical as well as the, I made a recommendation that it should be available to OBGYN residents too. So how, definitely it will start in Jamaica, but whether it will start, how our residents will go, we will have to tease it out. But once they launch it, then we can say that can we mimic it here? If you add us as a faculty, we will run that program, right? So because you have to have a set curriculum, you have to have the task written, and you have to have assessment also. So it is not that I came and I tied the knot and course done. No, you have to do it in a certain time, and then there would be like set goals, and you have to have tools, and we have to make sure that, and that is the only time when you will get. So the certification, these are the these are the most common one, will give you certification. But trust me, we are surgeon. Certificate doesn't really matter. You have to show what you can do. And laparoscopy, that's why it is very interesting. If you are a surgeon, you can probably hide because there's so much tissue that you can see something. And yeah. Where did you tie a knot? Nobody knows. The surgeon only know. But if you are a laparoscopic surgeon, everybody is judging you. Everybody, no, I don't think that's bile duct. No, not that. You understand? Okay, no, you should have gone 2 centimeters above. So this is actually very meditation and philosophical. If you are a laparoscopic surgeon, you automatically have to become humble because everybody is judging you. Okay, if you bring your ego in surgical theater, you're gone. Okay, you're gone, because it is documented also. It is not just everybody judging you, it go in a court of law. Okay, so the certification, these are the things will give you certification, but not necessarily certificate is more important. Okay, but the training is more important. And so what we could do, okay, so this is a small video. This is, if those people who have not seen, but I'm sure you guys must have seen this kind of task oriented things. And these things is very simple. If you go and do these things, you will definitely fail, right? Because you're doing it for the first time. But you can make your own trainer. These are the box trainers. When I started, I used to use the video camera and attach on a regular the light. But you can just use your iPad, put a triangle there. You don't even have to buy. If you have an iPad, you can make your own trainer. All these instruments, which the disposable one they throw, you bring those instruments and start doing things. So when you actually go, say for example, you go to a conference of AAGL conference in US somewhere, and there is a program, and then you can just pass it because you have done your practice already, right? And the written part usually would be your subject specific. If it is gynecology, it would be those kind of questions. If it is surgery, it would be those kind of questions. But this particular, the hand-eye coordination and depth perception, these are the things, they will always get done. But we have to make sure that we practice. Okay, a good laparoscopic surgeon practice at least the day the same day or day before surgery. So what are the challenges, right? So challenges is, one, if you want to set up a lab, ideally we have to have a simulation lab, because a couple of years ago when I attended a conference with Professor Ted Lee in Pittsburgh, they have a full setup, and the setup is you have computers and you have simulators there, and the residents will have a restricted what you can say, a protected time. So this is the time they will go and do their training on simulators. So that means you need an infrastructure, you need the physical space, you need the simulators, you need somebody who man it, need somebody who can take the inventory. Okay, it is actually time for us to have it, because we have surgical specialty and we have OBGYN specialty, and it is not just the endoscopic surgery. We have emergency obstetrics, we have deliveries and those kind of, how we used to do a prompt training. So the full simulation lab is actually need of time for us now. Not just a medical, we have something down at UWI, but that is for medical students. These are just the models for them to just see how the IV line and what the bones are and things like that. But for us, when we talk about the postgraduate programming in surgery and gynae together, we have to have a physical space and have a lab. We have to champion for that, right? And then we can definitely build some, I mean, these models, you can buy a simulator in $400-$500 from India, but you don't even need that. You can do it in $20. So if you are a resident, one, you have to do it, because if it become necessary to get you your degree, that means definitely you have to do it. If you are interested, if you are in a surgical branch, you have no choice but you have to be interested. Because trust me, every time as your patients getting more educated, they will ask you, why are you making this big cut? Can it be done laparoscopically? And then if you say, no, and now then they say, okay, let me go to the next person. So eventually the market will drive the thing. We are kind of slow people in Caribbean. We are very happy. We just trust our doctors. It's changing. They have choices. So it is coming. So as I said, for the recommendation, start early. You're young, start it. At my age, if I try to learn some skill, it's going to be neurologically, muscle wise, it is difficult. But when you're young, you can get these things done. Okay, stick out for courses, document your training, and go. I think in my last conference I said, everything is in the head. When you think you can do it, you can do it. And when you think you cannot, you cannot. Something like that. So you always have, but especially for these new skills, you have a mental block. You have to tell yourself that, yes, I could do that. Because, I mean, our generation, like Charles and I, and we actually just did it. There wasn't really anybody to train us. Now you, the younger people now, you have we don't really have a whole big department of minimal invasive surgery, but we have people who are doing minimal invasive surgeries. So stick with them, learn from them, learn from their mistake, do your courses. So basically what I'm trying to say is, that means all of us, we have to invest in ourselves if we want to get better. And minimally access surgery is the future, and you can't deny it. So better pull up your pants and get ready for it. Okay? We are here to help around. Thank you. Thank you very much.
Thank you, thank you, thank you, Dr. Vrinda. You make me want to go back to my song. Happiness is learning how to do MIS. So, does anyone have any questions for Dr. Vrinda? No? Okay. Well, I do want to make one shout out to the Hamilton group. You'll see some bags on your chairs. That's courtesy of the Hamilton group. Very impactful couple of Nadia and William Hamilton. They are family medicine practitioners and most notably recently climate change and environmental advocates, right? So they were in Abaco during the time of our biggest storm, Dorian, and have had experience of extreme climate exposure. And so out of that experience came their advocacy. They are also real estate agents, talk about diversifying impact in the community. And they have been kind enough to give us these gift packages. And so we thank you. You're welcome. Thank you very much, Dr. Vrinda. So our next speaker is Dr. Lorne Charles. He is a consultant obstetrician gynecologist, having graduated from the University of the West Indies in 1996, and he's been a medical practitioner for over 22 years. He successfully completed his postgraduate specialization in obstetrics and gynecology at the University of the West Indies, and further subspecialist training in laparoscopic surgery at the LapSurg Institute in Curitiba, Brazil. He is a member of the American Association of Gynecological Laparoscopists, a consultant obstetrician and gynecologist at the Princess Margaret Hospital, the walk-in clinics, and lead physician and owner of the Women's Specialist Medical Center. He is an examiner for the University of the West Indies Bahamas campus and has formerly served as vice president of our Bahamas Medical Association. He's a fellow of the American Congress of Obstetrician and Gynecologists and the Association of Gynecological Laparoscopists. Among his accomplishments, he started the Jadel contraceptive implant program for the prevention of teenage pregnancy here in the Bahamas, and he performed the first total laparoscopic hysterectomy at the Princess Margaret Hospital, and indeed followed on with a series of total laparoscopic hysterectomies at this institution. And so we welcome you, Dr. Charles, who will speak to us about building capacity and equipment for minimally invasive training.
Thank you very much, Dr. Nottage. I think I need that laptop for that wonderful and gracious introduction. Mhm. Okay, so it's my pleasure to present again in this effort, and I want to commend Dr. Lucas for keeping this going. Last year I presented laparoscopic hysterectomy as a procedure. This year now, I'm going to present the importance of medical equipment and the core requirements of medical equipment to establish and maintain a minimally invasive service in gynecology. So in gynecology, there are two broad categories of minimally invasive surgery. One is hysteroscopy, and the other is laparoscopy. Some of you in the room may know what these pertain to, but I'll just go further. So hysteroscopy involves visualization of the entire cervical canal, the endocervix, all the way into the endometrial cavity. And that modality has with it a number of procedures. Generally, the setup in terms of equipment for hysteroscopy would be a hysteroscopy tower, which would include an image processing unit, where resources are limited, we don't have to duplicate some of these equipment. So the image processing unit for the hysteroscopy could also be used for laparoscopy. So they could be sharing there. Camera could also be shared. Light source could be shared. In low resource settings, we just put up a bag of distension media and put a cuff and use that to pump. But the proper way to do it is to have a hystero pump that would actually give you a precise empirical reading of the pressure in the uterus during the procedure, which has bearing on fluid retention, etc. If resources permit, a fluid management system is a proper way to do it. So you'll know fluid in, fluid out, whether or not there's net retention of fluid during hysteroscopic procedures. So at the very least, a gynecological unit should have a diagnostic hysteroscope. And building on that, an operative hysteroscope, and building further, either of the two that follows, a hysteroscopic resectoscope or a hysteroscopic morcellator, and I'll get into more detail as to what these things are. So the diagnostic hysteroscope, I mean, every resident really should know how to use a diagnostic hysteroscope and to be able to describe the endometrial cavity with precision in a systematic way. Typically, these scopes have a very narrow outer sheath, 3 to 5 millimeters in diameter, so which means that there's no need for cervical dilation. So it's a purely diagnostic instrument, meaning you don't distort the anatomy by introducing dilators and distorting or changing the surface of the endocervix. It does not typically have instrument channels, and it comes in with a 12 or 30 degree lens. So this will be a core piece of equipment, I'd say, to introduce residents consistently, because the gold standard for investigating of abnormal bleeding in women is actually diagnostic hysteroscopy with targeted biopsy. We do blind DNCs now, sadly, because we did have a hysteroscope at one point. It got damaged, and it's been placed repetitively in budgets, and it's not been replaced. So you have a generation of doctors in the DM now who are not visualizing the uterine cavity, which is very unfortunate. So I would say this is a foundational piece of equipment. Building further on that, there's an operative hysteroscope, and this one has a slightly thicker diameter, typically 5 to 10, so you have to dilate the cervix in order to introduce this instrument. In many respects, it is exactly as the diagnostic hysteroscope, outflow, inflow tracks, but then there are instrument channels, as you can see, that scissor-like instrument there that goes through the sheath. And you could have a varied number of instruments. You could have scissors, graspers, etc., to grab polyps and to do some minor targeted interventions within the uterine cavity. So I would say this is also another good foundational tool for hand-eye coordination, etc., because hysteroscopic hand-eye coordination is a bit different from laparoscopic hand-eye coordination, because you're looking through a single channel and you're operating. It's almost like single puncture laparoscopy in terms of the ergonomics. So hysteroscopic skills cannot necessarily be extrapolated to laparoscopic skills in gynecology. It's two separate modalities, and it's important that residents get exposed to all these different instruments. Okay, so when I started, this was the instrument, the standard instrument for the hysteroscopic resectoscope for removal of, big pathology in the endometrial cavity. And this had a loop that had a monopolar electrode that would be used to resect fibroids or perhaps sometimes remove the entire endometrium as a kind of ablative procedure. But we had to use non-electrolyte distension media, and the surgeons will be familiar with TERPs and that whole syndrome of retention. So that was a risk with that, and that has subsequently improved to a bipolar instrument, the same function, same design, but now allowing normal saline, which had a bigger tolerance for retention and excretion. And this is being replaced with this hysteroscopic morcellator in this particular slide.
which is a device that has no energy. So the risk of perforation is literally it's extremely low because there's a reciprocating blade there that oscillates at a certain frequency and chops the fibroids up. It's a complete system that sucks the debris into the channel, leaving a nice, clear visual field. So the setup involves a pump to maintain hydrostatic pressure, so the uterus is always dilated no matter what. This reciprocating blade chops the actual specimen up. It gets aspirated instantaneously into the channel and collected for pathology, and the pump automatically compensates for the loss of fluid during that aspiration phase and keeps the uterus nicely dilated. Visualization is wonderful, and it's a really great instrument. It does not have any cutting ability at the tip. So as you can see, the blade is actually placed along the axis, so you can't actually poke and drill through the uterus with this instrument, which is really a milestone in safety, because the one I described earlier, the resectoscope, you could actually burn through the uterus with that loop. So things are changing. So this is now replacing, because it has so many advantages. It's a complete system. It includes fluid management, specimen collection, all built into a comprehensive package. So this is essentially going to replace, I think, the resectoscope. And if I'm in a low resource setting and I had to choose one, I would choose this as my instrument of choice for uterine pathology. So this is basically the full range of equipment for hysteroscopy. This would address fibroids that are pedunculated into the cavity or partially protruding into the cavity, polyps, biopsies, even synecdoche with the operative scope. So if you have a diagnostic scope, an operative scope, and this oscillator, you pretty much have a comprehensive toolkit for proper exposure to hysteroscopy. And equipment is very important, because when I did my training, as Dr. Brunda suggested, you train, you get a certificate based on a certain volume, exposure, demonstration of aptitude. But when you return back to your home country, you have to keep that volume going. In fact, when I did it, I had to actually purchase the laparoscopic tower and the hysteroscope myself and install it in the public hospital just to keep the volume going and to demonstrate that these procedures could actually be competently done. Okay, so moving on to laparoscopy, the surgeons will be quite familiar with the typical tower, the monitor, light source, electrosurgical unit, image processing. So I'll just go through each of these elements separately. So image processing has, gotten better, standard definition to HD to 4K. With the resolution increase, you also get better color depth. So you're able to identify and discern tissue much better with the new visual technologies. For gynae, we'd also need a gas insufflator. In particular, we like to choose the high flow rate, the 42 LPM, as opposed to 30 liters per minute. Because when we do laparoscopic hysterectomies and we make a colpotomy incision, all the gas blows out of the colpotomy incision into the vagina, and the abdomen deflates, collapsing the field. So you need a high flow pump to maintain pneumo. Light source, when I started, it was xenon. Now it's LED. It's brighter, it's whiter, less hot, doesn't harm tissue. So there's been improvement across the board. In terms of energy, monopolar and bipolar still exists. That's all I had when I started, actually. Monopolar and bipolar as my energy. There were no vessel sealers available here yet at that time. And if I'm doing a hysterectomy, I had to meticulously cut in very small increments. I couldn't grasp with confidence and get a full seal segment as we do with ligature, etc. So monopolar, just the gist of the physics of it, the current goes that through the patient. There's a dispersive pad on the patient's thigh, and when you apply the current, it actually conducts through the patient's body. And as a result, it's very good for coagulating surfaces and surface bleeders, but the risk here is thermal spread. It has high thermal spread and could damage adjacent tissue. So you have to be very judicious in your use of monopolar technology. Bipolar is the current only goes through the jaws of the instrument. So it's only the tissues that is coapted in that instrument that will actually experience the electric current. So it's a bit safer and it's good for vessel sealing, etc. Vessel sealing technology came along, and that actually created a huge, I mean, that was reflected in the reduction in time to do the procedure. It took me 3.5 hours initially. When Ligashore came along, that came down to like 90 minutes, the same procedure. These are also bipolar instruments, the vessel sealers, but they have a more precise method of creating that collagen seal and assuring vessel occlusion up to 7 millimeters. Um, and there are two types. There's Ligashore and there's another brand called N-Seal. It's a matter of personal preference. Ligashore is very, I don't want to say dummy proof, but it gives clear indication as to when the seal takes place. And so it's very good, easy device to learn on for residents. N-Seal is a more nuanced device. It does not give the same alarms and indication of when the seal is formed, so it requires a bit of experience. There's a learning curve there, but it is a more versatile instrument. It's a better dissector. The tip is a better dissector. And the tip in the latest version could actually articulate to give a right angle approach. This is useful when we are getting the uterine arteries, because the view is that we're looking down on the uterus along its axis, and you want to get the vessels on the side, and this articulation allows us to do that. Then there is the harmonic scalpel. I understand that we're going to be getting that here soon. No, I heard that we maybe pre-releasing a new album. Huh? Yes. 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 But actually the representatives informed me that it should be coming soon. So this is another option. This is extremely good. The principle of this works. This is not bipolar. It's a piezoelectric crystal that vibrates the jaws at a high frequency, produces heat, cuts tissue. It has exceptional tissue thermal spread characteristics. Is actually the least, is less thermal spread than Ligashore, less than N-Seal. So it's a very safe instrument. The jaws are very thin, as you can see, and finessed, so you can do really good dissection with it. Only thing I would say is that is a learning curve. It does not give the same alarms as Ligashore in terms of saying when a seal is formed, but with experience, it could be an all-in-one instrument. It's a great dissector. Because when I use Ligashore, I use it to seal a vessel after I've exposed the vessel appropriately. But that exposure, I achieved that with a Maryland or something else with a finer jaw. But this is actually an all-in-one. You don't have to change instruments if you're using harmonics skillfully. So this would be a great addition. But you don't have to get all of the above. You could either get a Ligashore, an N-Seal, or a harmonic. So they all have their pros and cons. So I'm not suggesting that we get all three, but that would be nice, of course. And now there are specialized generators. Most of you be familiar with the force triad that has monopolar, bipolar, and Ligashore in there, built in. So that's a pretty good all-in-one solution. So that will be the investment that the hospital will make. They'll buy the force triad. They'll have a stock of, so they'll have a stock of Ligashore, monopolar hooks, and so on. And they could also do bipolar instruments. The other proposal will be the N-Seal and harmonics in one generator. I don't know if the N-Seal people are here. So this is also interesting. This does not have monopolar or bipolar in it, so you'd have to have a separate unit for monopolar bipolar, which we'll have anyway because we use that for open surgery. So if you have monopolar and bipolar instrument unit available, N-Seal is a consideration with harmonics. So things are improving. All of these systems, huh? Right. So let me just segue into how, generally the trend has been that it's been lower and lower hanging fruit to set up an effective service in terms of the capital investment. So in some instances, some companies will donate not donate, but they will loan you the generator just so that you use their consumables. That's a bargaining approach, where if you want a particular technology, company may place a generator in your unit and just have you have an agreement to pay for the consumables. Hmm. Hmm. It's been, yeah, yeah. So onto the trays. For gynae, we need to have a good general purpose tray. So what I've noticed from when I started to now. When I started, I bought an extremely expensive set of reusable instruments. Um, so this good general purpose tray should have Marylands in there. They should have atraumatic bowel graspers, monopolar hooks, etc., suctions and all that. The trend that's been happening, well, I'll tell you the pros and cons of that. You make a big outlay in expense to buy a set of disposable, reusable instruments, Carl stores or whatever. And the only way you recover that capital investment is if these instruments are very well cared for over the years. When the CCB was built, there was a massive amount that I was spent, millions of dollars, tens of millions of dollars on reusable instruments. And I think maybe in the space of 5 years, the half-life of that, I mean, it's embarrassing. It's like most of those, many of those were no longer useful, were not properly processed. Now, the processing of these instruments are extremely meticulous. Some of these things have four parts: inner shaft, multiple channels, jaws, and all that to reassemble. You have to take it apart into four pieces, clean it, tiny screws, etc. So if you don't have proper, I used to clean my own instruments, which I purchased, just to guarantee that it's going to last me a while. So I would say that that's a drawback in this setting. It seems sensible from the outset that you're going to get something that you could reuse and you're going to gain, but I think the cost benefit is debatable. If you go for disposables, which are becoming more accessible, a bit cheaper, and with better systems like LigaSure, you find that you need less instruments to do a particular procedure. So two things are happening. Technology is improving. You need less instruments to do a large number of cases. You don't have to change as many instruments. And with a disposable system, when you open that up, it's always complete. And there's no processing time afterwards, and it's readily available. So I think disposable versus reusable could be a debate. For gynae, so apart from the general purpose tray, for gynae, you will need supplemental systems for laparoscopic hysterectomy, tubal ligation, specimen retrieval, and morcellation. So in addition to the tray, so I'm defining what it takes to have pretty comprehensive gynae capacity from a laparoscopic standpoint. General purpose tray, and the clip, the tubal ligation is a special system. This goes through an 8 mm port and is a titanium clip system that clamps the tube. I have it in that diagram there that shows. You can see in this with the successive closure of that how it occludes the tube. So that's a separate piece you'd have to buy separately for your TL. For laparoscopic hysterectomies, there are two necessities. One is you need that thing that looks like a cup. That's something that delineates the vaginal wall. So the cervix goes, the middle of it goes into the cervical canal, and the circumference of it delineates a region around the cervix in the fornices, that from the abdomen you'll be able to see with caudal advancement of that instrument exactly where you need to cut, and it provides us kind of tissue tension, which is a necessity when using monopolar current. So that instrument, whether it's the one on the left with the green or the other one on the right, that is a very key part, a very important piece of doing a safe laparoscopic hysterectomy. So that instrument advances it, delineates the cuff so you can see it clearly after you've moved the ureters and all that aside. And you can make a nice circumferential incision and achieve that colpotomy cut to remove the uterus from the vagina. In addition to that, they always is always coupled with some kind of device to retain the pneumo by occluding the vagina partially at least. So that little blue section is meant to do that. That's advanced into the vagina to act as a kind of barrier for airflow exiting the vagina. And the other one on the right has actually an inflatable balloon. I don't know if you can see it. It's wrapped around the base of that instrument. So it provides both occlusion and safe delineation of the vaginal vault. And with caudal advancement, it pushes all of that away from the ureters, which fall inferiorly. So this is a very important aspect of safe execution of a laparoscopic hysterectomy. So we'd have to get that. And when I started out, we did actual suturing with regular sutures. We started with extracorporeal suturing. So there were systems where you tie extracorporeal knot and you keep pushing the knot down. I think that's becoming a little bit out of vogue. Yes, I'm not saying is useless, but I'm just saying trends, you know. So and then I had to learn how to do intracorporeal knotting as well, because that's all we had. And now they're barbed sutures, which I must admit has made all a bit lazy. Doesn't involve any knot tying. It's pretty efficient. All of this serves to reduce time and make the procedure more, efficiently executed. Okay, so the laparoscopic morcellator, this is an essential extra piece as well, because if you don't have that, there are many things you cannot do. You cannot do a subtotal hysterectomy, for instance, because if you do a subtotal, you amputate the uterus at the cervix, you have no way of extracting that organ from the body. So these, they could be 20 millimeters, 18 millimeters, 15 millimeters in diameter, these morcellators. So you extend your 10 mm incision, and you introduce that with a tenaculum and you grasp whatever tissue and it grinds it up and it allows you to do that. So in the case of a subtotal, it makes that possible. Without that, it is not possible. Not without creating a very wide incision, which defeats the purpose. And myomectomies is also important for big fibroids to remove them. And finally, robotics, the next frontier. So just as we're about to get a handle on regular laparoscopy, every conference you go to in the US, they refer to what they call straight sticks, as if we cavemen doing laparoscopy, and we think that we advance here, which I think is all marketing. I mean, I think regular laparoscopy is still a great skill, and I think we should develop that. The benefit of the robot really is to lower, is almost like a catalyst to lower the skill set required to do minimally invasive surgery, because it is more natural in terms of its field. Stereoscopic vision, a large degree of motion that allows a lot of dexterity, no tremor. The instruments with the robot is typically multi-use, so you can use the vessel sealing device several times, quite a number of cases. They claim that as a cost benefit, but the capital cost of the robot is the barrier. It's like 2.5, 3 million for the Da Vinci. That is also advancing itself. I mean, in terms of training residents, the current Da Vinci is loaded with the movements of expert surgeons as a kind of benchmarking AI in it. And every case that's done is recorded. And this now allows residents to process along, to matriculate through training steps and improvement, basically economy of movement. So it kind of scores you how you did the case, the time taken, and how many steps to do a particular, how many movements to do a particular step of the procedure. I would imagine in time, the robot might have a bit of autonomy, being able to recognize the field, just like your Tesla car recognizes the road. Would be able to identify tissue and do basic surgery over time. So that is a gist of what's needed to set up a core capacity in terms of equipment in gynecology. it is extremely important part of training. Dr. Varunda explained the initiative that the resident must take to go get the skills, which are changing, and perhaps you don't always want to get it from your indigenous setting. You want to go abroad and get some exposure, see what's being done, new equipment, etc. After that training is done, you have to come back and meet some kind of physical capacity to keep your volume going and to keep the skills honed. I think it is lower hanging fruit. I think the industry is moving, and with robotics being the emphasis now, I think even laparoscopy will be even more accessible to developing countries because it'd be cheaper systems. I remember it was so expensive, like probably $200,000 for a tower. Now you could probably get a tower for like $40,000. So things are moving in the right direction, and I would encourage the residents as well to. You have to immerse yourself in the field. You cannot expect it to be spoon fed to you. That's the gist of my talk. Any questions? Comments? No questions? No comments? Well, thanks again.
Thank you.
Yes, and congrats for
Oh, good.
comments.
Wonderful.
Yeah.
We need a microphone in the back. Dr. Varunda has a comment.
Hello. Thank you very much, Dr. Charles, for the update. I just wanted for you to just tell us what we have, so that at least they get idea, right? So let me update. If Charlie didn't do that, I can do that. We do have adequate set for residents to start doing simpler cases. So what I mean by that is we probably don't have morcellator, we don't have ICD, which Dr. Wesley said, we don't have harmonic, but yes, we have ligusure. We don't have bipolar at this time. For whatever reason, our bipolar gone bad. We don't have bipolar. We have monopolar, and we have forced triad. Yeah. No. I mean, the bipolar devices, bipolar instruments have gone bad. Because remember, you have the ceramic and then you had an insulator at the tip. When we have the Robi bipolar from stores, so they gone bad. So we don't have them. I mean, it is not. Yeah. But we need some bipolars for that. Yeah. So we don't have bipolar at this time. Our camera system started wearing down. So if you are doing any case which is longer than say hour and a half, the system starts sleeping. So you get the grainy pictures, you get the camera start, you don't get the depth. So it is hard to do longer cases. But definitely simple cases like appendectomy, depending upon your skill level, cholecystectomy and tubal ligation, salpingectomy, ovarian cyst, these are the low hanging fruits, and we have enough material or enough supplies in our, that means PMH, I'm not talking about doctors, to handle it. Where do we? Right. But what I right. Okay, yeah, that is good. No, I didn't experience that as yet.
And in terms of mentorship, in terms of skill acquisition and practice at home on your own, and seeking out ways to make yourself better. And Dr. Charles spoke about how we can ready our environment in terms of equipment and the investment that's needed. Speaking of equipment, I do want to acknowledge and thank Ports International, who are here and supporting us, and Medtronic, both of whom have contributed to our training environment and our practice environment. So thank you. And they have some very interesting equipment on display that you can see outside and that we'll be using a little bit later. So the final presentation in this section for gynecology and training will come from Dr. Saida Bowe. I think she'll be joining us over Zoom. Dr. Bowe is currently the Chief of Services of the Department of Obstetrics and Gynecology at the Rand Memorial Hospital, that's in Grand Bahama. She did a fellowship in gynecologic oncology at the Foothills Hospital in Alberta, Calgary. And Dr. Bo has been involved in research work with the University of Miami regarding genetics and women's cancer. If we can load up Dr. Bo, she'll take us to the close of this section on gynecology and minimally invasive surgery. Thank you.
Go ahead and control them. Mhm. No, we can't see the screen. It's good now.
It's not so much of a journey, I guess, but nonetheless, what can be done, what should be done based on international standards is what I will be talking about. So you can find my objectives of the presentation. Gynecologic cancers, as we all know, include endometrial cancer, cervical cancer, ovarian cancer. It also includes vulvar cancer, however, did not include vulvar cancer because while it is surgically managed in terms of MIS, there's minimal involvement of MIS in vulvar cancer or vaginal cancer management. The optimal surgical route for the treatment of gynecological cancers, though, still remains controversial, and it's more controversial in low middle income countries. In high resource settings, most of those cases are being done via minimally invasive surgery, whether it is laparoscopic or robotic surgery. As Dr. Charles said earlier, most conferences where you go to, people are talking about doing everything robotically. You know, you have persons that only do hysterectomies robotically and think that laparoscopy is kind of dinosaur. So definitely open surgeries for them is just like, who even does open surgeries? We also have the ability with MIS to do just lymph node dissections, whether it's pelvic or parietic lymph nodes. And this is particularly important in patients that may have had a hysterectomy performed, and then after the final pathology is revealed, it is an endometrial cancer or an ovarian cancer. And now the patient should be staged. These are patients that can then go back to the operating theater for lymph node dissection and have these done MIS. So in terms of endometrial cancers, the surgery was previously performed via laparotomy, but now there is a worldwide shift to MIS. The advantages, obviously, to MIS would be decreased perioperative morbidity, especially in patients with high BMI. Now, we've done several studies in gynae oncology looking at the advantages of MIS surgery for our patients with endometrial cancer. One of the landmark trials was that of the LAP2 trial that was done in 2009. And this study, there was a 2-to-1 randomization of patients with clinical stage 1 to 2 endometrial cancer. They had 1,696 patients that were performed laparoscopically, and then 920 were laparotomy, 25.8% conversion rate. The reasons for conversion were bleeding, poor visualization, and metastatic disease. In 74% of the patients, staging was actually completed. minimally invasively. The only drawbacks that they found was the length of time for the surgery when patients had their surgery done via minimally invasive approach, and there was less lymph node dissections done in the minimally invasive group. But at this time, minimally invasive surgeries were new, so it was considered that that was not so much of a drawback, but just in terms of skill set of the surgeons. And in overall detection of advanced disease, it was 17% versus 17%. Then there was a follow-up trial or follow-up results released in 2012, and the primary objective was non-inferiority for recurrence. And there was really no difference. The 3-year recurrence rate was 11.39 for MIS compared to 10.24 for laparotomy. And 5-year overall survival was almost 90% for both. So this basically allowed or led to the guidelines and the multiple position papers resulting in MIS being the way for endometrial cancers. Robotic surgeries for endometrial cancer is actually favored in persons with large BMIs because we know that there is now the challenges with maintaining airway given the steep Trendelenburg that would be required if you're doing it laparoscopically. But doing the surgery now robotically, it's much better for bariatric patients, which most of the patients with endometrial cancer are of a high BMI. The other advantage to MIS surgery in endometrial cancer would be that of doing sentinel lymph node mapping. Now, I know we do not have ICG available, but it is one of the gold standards for patients now with an endometrial cancer diagnosis to have sentinel lymph node mapping as a result of the FIRES trial, which showed that these patients actually, there was a over 95% detection rate for patients with ICG sentinel lymph node mapping. So in terms of cervical cancer and how that MIS is involved there, first laparoscopic radical hysterectomy was actually described by Nezat et al. In 1992. Stage 1A1 diagnosed after colonization can be managed via MIS with a simple hysterectomy. Sentinel lymph node biopsies, again, this is where this would be ideal, replaces full lymphadenectomy, and procedure will allow high detection rates. The LAC trial. This was a trial done by Ramirez et al. And released in 2018. It was a non-inferiority trial with 631 patients with stage 1A1. They had lymph vascular space invasion 1A2 and 1B1. These patients had radical hysterectomy via MIS or laparotomy, and one of the MIS routes was robotic surgery. The disease-free survival at 4.5 years was 86% versus 96.5 for patients MIS versus open. And the 3-year overall survival was 93.8% versus 99%. So there was a higher 3-year overall survival in the open route. As a result of the LAC trial, MIS use in cervical cancer then subsequently declined, and the open surgery route was preferred. And this is in most of the guidelines, NCN guidelines, ESGO guidelines, they all recommend the open route for radical hysterectomies. MIS at this point in cervical cancer patients is particularly used in fertility sparing procedures. So if the patient is having a radical trachelectomy, then this is done via the MIS route, but it's no longer recommended to have a radical hysterectomy performed using robot or laparoscopy. So in terms of ovarian cancer, laparotomy is still pretty much the standard approach, and it's utilized in MIS is utilized in some patients with early stage disease, so stage 1 or 2. And reason that there is no push to using MIS for ovarian cancer is because there's not any randomized controlled trials comparing laparotomy to MIS. There was, however, a large observational study with over 8,000 patients with stage 1 epithelial ovarian cancer, and they found that capsule rupture occurred more commonly, which resulted in increased mortality. So when we stage ovarian cancers, if there is capsular rupture, it upstages a patient, and ideally in a patient with ovarian cancer, it is to remove the cancer intact without a capsule rupture. Even if a patient is an undiagnosed ovarian cancer and a generalist is taking the patient to the operating theater for an ovarian cyst, it's ideal to not allow there to be a rupture so that this patient does not have to be upstaged. However, where can we use MIS in ovarian cancers? It's utilized for diagnostics and to obtain biopsies. So in patients that you know that there is some omental disease, or there may be uncertainty as to if there is disease outside of the pelvis, then a diagnostic laparoscopy should be offered to these patients. And these patients, when you're doing the diagnostic laparoscopy, can have a Foucault scoring performed. And this is here the Foucault scoring system. And it looks at all of these areas, and patients with a score greater than 8, these are patients that are considered to be unresectable at the time, so they should not proceed then with open laparotomy, but instead these patients should then go on to receive neoadjuvant chemotherapy and then have an interval debulking surgery. If the score is in question, it is recommended, though, however, that there is a second observer or second physician that is present that then goes ahead and scores the patient. And the average of the two is looked at to see whether or not this is a case that can be performed. Now, I know in our setting, using the scoring system has its advantages and disadvantages. One of the advantages would be, you're not taking a patient to the operating theater to look to perform a debulking surgery, and then you're not able to perform the debulking because the score is above an 8. But at the same time, when booking these cases can result in a possible laparotomy if the score is less than 8. So then in terms of OR booking, there is that possibility that you now may overbook a list or underbook a list given what you're anticipating at the time. So I know some of these were previously discussed in terms of advantages of MIS, but just to reiterate, there is reduced postoperative pain, shorter hospital stay, less blood loss, faster recovery, lower infection rates, and small incision. And why MIS is so important is because I know we're all looking towards ERAS, and ERAS should be where we're all headed in terms of managing our patients surgically, because we want to get them out of the hospital as quickly as possible. We want to make sure that they're not using opioids. So minimally invasive surgeries do actually align with ERAS protocols. And I thank you all for your attention, and I will welcome any questions or comments. Hello?
My mic.
Yes, I can hear you.
Oh, great. Thank you so much, Dr. Bo, for your presentation and for taking the time out to be with us today, even via Zoom. So do we have any questions in the room? No? Well, we've had a wonderful segment from gynecology. You do? Yes.
Just a quick question, Dr. Bo. I'm hoping you can hear me.
I can.
What's the average disparity in time between an open, for example, periodic node dissection versus the laparoscopic or minimally invasive approach?
So I have not seen any studies looking at the time for comparing open lymph node dissections. It was in the lab trial that the open surgeries was like 200 and some minutes compared to, sorry, the laparoscopic with 200 and some minutes compared to the open being only 125 minutes. So there was at that time the disparity in terms of minimally invasive compared to laparotomy, but lymph node dissection, no, I did not see anything now. There is also the different approaches to lymph nodes, whether you're going to go extracorporeal, not extracorporeal, sorry. It's going to come back to me. I will answer you with that one, but there is a different approaches to getting your paraortics compared to the pelvic lymph nodes. And so if you're doing both, then it may be a bit longer depending on the route that you decide to start with first.
Extraperitoneal or retroperitoneal
Yeah,
approach to
thank
the
you. Thank
aortic
you
area.
very much. It was
That's from
like,
Dr.
it's
Taylor.
right there.
Yeah. Thank you so much. Thanks again, Dr. Bo. So we will be heading into our next grouping of lectures. I just want to remind us all, please, to try to stick a little bit to time. We are running over and people will be hungry soon. We want everyone's attention to stay focused in this room. And so we're tying up this morning and we're moving right into the next segment. The moderator for the next couple of segments will be Dr. Nadia Holder, who is my colleague, my medical school classmate. I actually met Dr. Holder in Jamaica. Yes. And she married another colleague of ours, Dr. William Hamilton, who's Bahamian and came to Bahamas. And here they have built a wonderful life. And I think I spoke a little bit about them. They are behind the Hamilton Group and the wonderful goodie bags that we've been given. So, Dr. Holder, thank you.
So, good morning, colleagues. How is everyone doing this morning? Yeah, let's look excited. We're happy to be here, right? Okay, so thank you again, Dr. Bo, for bringing our ONG sessions to a thoughtful close. And we are going to shift now to cardiovascular and the cardiovascular frontier. So, this is where, of course, the evolving techniques and some clinical judgment continue to be redefined in cardiovascular. I'm not partial, okay? Our next speaker has been at the forefront of this evolving landscape, offering both insight and clarity in a complex and rapidly advancing field. Dr. Lemuel Pran completed his postgraduate training in general surgery in 2018, followed by a fellowship in vascular surgery at King's College Hospital in London in 2020. In 2022, he was awarded the gold medal in the European Board of Vascular Surgery examinations and holds fellow status with both the American College of Surgeons and the Royal College of Surgeons of Edinburgh. He has authored over 20 publications, including editorials, case reports, original research, and book chapters. His clinical interests include carotid surgery, management of the diabetic foot, and renal access for dialysis patients. Please join me in welcoming Dr. Lemuel Pran, who will present Aortic Surgery, the Trinidadian Blueprint for TVAR. Thank you, Dr. Pran.
Thank you very much for that kind welcome. So, firstly, I'd like to thank the organizing committee and Dr. Lucas for inviting me across to your wonderful part of the Caribbean to share this talk and to share this time with you guys. I must say the hospitality of the Bahamian people is exceptional, and I'm really enjoying it. All right, good. So, as highlighted, my talk today is on the aortic surgery frontiers, the Trinidadian blueprint for regional TVAR success. So just to give a little background, so Trinidad is probably the southernmost Caribbean island closest to Venezuela, and our population is approximately 1.5 million people. The hospital where I work, it's one of the three major hospitals. It's the only hospital with a public cath lab, and therefore we sort of, I would say that we are the hub of vascular surgery for our country. Some of my colleagues may not completely agree with me on that one. So just to say, I have no disclosures or conflicts of interest with respect to this talk. I am a full-time lecturer with the Department of Clinical Surgical Sciences with the University of the West Indies, and I also fulfill full consultant clinical practice for my regional hospital, Eric Williams Medical Sciences Complex. It would be amiss of me if I didn't recognize our team because, with vascular surgery is very highly intensive and therefore we require a team with special mention to my colleague. Well, initially I trained under him as a resident, so he was my senior mentor and now colleague, Dr. Dave Haranan, which is that gentleman in the lower picture there. As you can see, I've learned a lot of things from him. So what I plan to do today is just to provide a bit of introduction in terms of aortic stenting, go through some of the indications for aortic interventions, which some of us may know. What are some basic principles that we employ when performing aortic stenting? We'll review our local 10-year experience of aortic interventions and specific mention on TIVA, and then we'll review a couple of those cases in which we encountered. So Juan Parodi is the pioneer and godfather of aortic stenting. And his first, his landmark publication, his landmark case happened all the way in 1990, approximately 35 years ago in Buenos Aires in Brazil. And as, there's a saying that when it is you are limited in terms of resources, that is an ideal environment for innovation. And therefore, I'm sure that at that time, Professor Parodi, he was thinking of how can I treat this patient, this as you could see in the excerpt there, this is an article from the Annals of Vascular Surgery 25 years later, meaning a heavy smoker with a 6-centimeter aneurysm, what's the best way of treating this patient? And that is where aortic stenting was birthed. He later went on to do the first aortic stenting in the US at the Montefiore Medical Institute in New York. So I say all of this to say that 35 years down the line, aortic stenting has now become commonplace in the management of aortic disease. And therefore, within the region, we have to figure out where we are and therefore how are we going to be able to achieve or get to a point where we can say that it is now also commonplace for us. So these are some landmark trials which some of us may be familiar with, which basically has provided the platform for aortic stenting, meaning the EVA-1 trial, the DREAM trial, and the OVA trial. Now, these trials have concluded that there is a significant benefit in terms of the short and medium-term morbidity and mortality for patients having aortic stenting versus open surgical repair. In terms of the indications for aortic interventions, we could break it up into two main areas, meaning in thoracic aorta and the abdominal aorta. The thoracic aorta, indications would include any patient that has symptoms or has so the way I remember it is the S's of aortic surgery. So you look for symptoms, you look for the size, and you look for saccular aneurysms, because all saccular aneurysms, regardless of the size, they need to be treated. So the symptoms in the chest that you would look for would be, central chest pain. They may have esophageal compression, etc. The size for the thoracic aorta, in some publications, they have indicated 55, but some go even up to 60 or 65, but the general consensus is once you start hitting 55 millimeters, you should consider some form of intervention. And then there's always that interval increase in the size on your surveillance, meaning 5 millimeters in 6 months or 1 centimeter in a year or 10 millimeters in a year. Similarly, a lot of the trials, specifically the ADAM and the UK small aneurysm trial, have established that in a man, size of aneurysm that is more than 55 millimeters should be intervened on, in a woman 50 millimeters, and any aneurysm that is symptomatic, as you mentioned before, and any saccular aneurysm. So what have we done in terms of aortic interventions in Trinidad over the past 10 years? So overall, we've intervened on just over 100 cases. And that was split into roughly 80% being on the abdominal aorta and just 20% being on the thoracic aorta. If it is you look at that, this lower box here, we can see that open surgical repair was performed in 73% of patients compared to an endovascular approach in 26. Now, if it is you look at first world countries, this ratio is actually probably inverted, where the majority of patients in, let's say, the US, UK, Canada, they are being intervened more frequently using an endovascular approach versus an open surgical approach. And this is one of the main takeaway points from this slide, is that there is a role and there's a lot of room for us within the region to push a bit more to get ourselves into that minimally invasive era in terms of aortic interventions. Of note, in terms of the thoracic aorta, although the overall percentage was just 20%, 90% of that 20 will actually intervene with an endovascular strategy. So specifically, and this may be biased because obviously as vascular surgeons, we're not very comfortable going into the chest, and therefore our only option for intervention technically for the thoracic aorta would be an endovascular approach. And lastly, I would say probably 9 out of 10 aneurysms that we do in Trinidad are open abdominal aortic aneurysm repairs. So when considering aortic stenting, what are some principles that we need to adhere to or need to consider? Firstly, anatomical considerations, because the anatomy of the aorta, the anatomy of your aneurysm, or whichever pathology you are encountering, you need to study it well and you need to know exactly what's going on there. The other thing you will have to consider is where you're going to get your access, because this is a device that you have to implant, meaning from out into the body, and we usually use the femoral artery access, and then how you're going to close that access. And lastly, what are your options for endografts that you can use? So this table just highlights some of the various types of endografts that we have available to us. And each endograph is unique in its own way, which you would then use those features of that endograph to determine the best suitability for your patient. What you should never try to do is fit an endograph to your patient. You should always try to use the best endograph that is appropriate for your patient. Having said that, in the Caribbean and in our region, the Medtronic graft is the one that we have most easily available. And I can say without any reservation that all cases that we have performed TIVAs on and even EVAs have been Medtronic grafts, just because of the market and the availability of getting a graft within the region and in the Caribbean. So when we talk about anatomy, this is one example where on the right-hand side, you can see this is taken from the ESVS aortic pathway workshop, where you have to do something called a planning. And this is what a typical planning sheet looks like. And therefore, your planning sheet will determine your anatomy of your neck. And therefore, the anatomy of the neck, you would want to know the length of your landing zone. You would want to know the diameters. And if it is, you see here, you look at what we call zero, just at the renal and 5 millimeter increments until you see the flare of the aneurysm. So that is very important. Aside from that, you want to look at angulation, you want to look at thrombus, you want to look at calcifications. All of these are features of your neck or of the aneurysm neck that will then translate into whether there's what suitable endograft that you might be able to use. Aside from that, you want to look at where the aorta bifurcates, because this needs to be a certain diameter to facilitate your graft and avoid kinking of the ipsilateral and contralateral limbs. And then you want to also look at this, I touched on this before, the size or the diameter of your femoral artery that will allow you access. So generally, you won't want a femoral artery that is less than 7 millimeters, because most devices are delivered through, let's say, a 18 or 21 French. So if 18 or 21 divided by 3, you'll get 6 or 7. So a vessel that is less than 7 millimeters could result in your inability to get access, or the complication of iliac on a stick. Because basically when you're taking your device out, you basically avulse the the external iliac artery, which has happened to me. So you can do your own, what we call planning, or you can send it to your company, and they use special technology like Fusion or even Tremensio, and they will then do this reconstruction of the aorta, and then based on those various diameters, they will fill the sheet out, and then they will recommend a product that would be more suited. Now, I would always recommend that, yes, you send your scan to them and you see what their recommendation is, but you also need to be clear in your mind that you are happy with this recommendation. Yeah? Just to say that when doing aortic stenting, you need to do something called oversizing. Meaning, if it is the aorta is 25 millimeters, you can't get a 25 millimeter stent. So you need to oversize anywhere between 10 to 20%, so that you prevent graft migration. Oversizing too much can result in a type 1 endoleak, because you can have what we call crimping of your graft proximally, and a type 1 endoleak is a big problem because that requires intervention. It's not one of those that you can just sit on and watch. So this is what reconstruction and planning would like for an abdominal aortic aneurysm. So when thinking about aortic stenting in the thorax, anatomy becomes very, very important. And these are just some variations of what we call the bovine arch or bovine anatomy. And these need to be studied and considered, and therefore knowing your anatomy and knowing if there's an aberrant anatomy is very, very important. Aside from the anatomy of the arch, you need to know about your zones. And I believe some of the residents would have gone home yesterday and learned about the zones, because we had a little bit of a session and the zones were a bit mixed up. But essentially, if it is you can get a zone 3 landing, that's ideal. Anybody would be happy when they're doing a TY if they could get a zone 3 easily. It's the problem comes where, but most cases, I would say maybe 50%, you will have to do a zone 2 landing. And therefore, if it is you're doing a zone 2, then you have to determine how are you going to manage your left subclavian artery. All right? So the zones of the thoracic aorta are very important when considering TIVA and TIVA stenting. And this is what a TIVA planning, just like the abdominal aorta, what it would look like. So you have your reconstructed image, you have your various diameters, and then based on your degree of oversizing, they will then recommend an appropriate size graft for you. So with respect to the thoracic endovascular aortic repair from 2015 to 2026, so roughly 10 years, we've done overall 20 cases. And the most common pathology we encountered was a grade 3 blunt thoracic aortic injury, which accounted for 40%. Of this series, so it's a series of total of 16 patients. 4 patients are still pending repair because they've come in, they've had this injury, we couldn't stent them, they remain stable, and now they have been discharged trying to get the stent. However, we have also had 4 patients who died while waiting a stent. And of these 4 that died, at least 2 of these patients, I think, were salvageable had we had a stent in a timely manner. And just for the guys there who may not know what in terms of the grading of the injury, so a grade 1 injury is what we consider an intimal tear. Grade 2 is called an intramural hematoma. Grade 3, which is the one we most commonly see as pseudoaneurysm. And grade 4 is free rupture. So these guys who died, they probably presented as a grade 3 or a contained rupture, and then they progressed to a grade 4 rupture with rapid exsanguination. It happens in a matter of minutes, 3 minutes, and they're gone. We did do stenting for 6 cases of type B aortic dissections. One particular case that stood out to me is this is a case who she presented acutely with a medial tear. She was dropping her hemoglobin, becoming unstable, and we had to do a TIVA for as an emergency procedure. So I see my colleague there is because type B aortic dissections in the acute phase, they are mostly managed medically. But this lady was dropping her hemoglobin. Luckily for her, we had 1 stent in the country that we were able to use for her. The other 4 cases were that of pseudoaneurysms as a result of penetrating aortic ulcers, and we had 2 cases where we stented for thoracic aortic aneurysms. So I'm just going to go through a couple of the cases. So this is one example of a blunt thoracic aortic injury. Here we see left subclavian, outpouching or pseudoaneurysm, a typical point just distal to left subclavian. Seen here on the axial images, this is not atelectasis, this is blood in the chest. All right? And then he went on to have a TIVA there, sealing that and excluding that pseudoaneurysm. This is the case of the acute type B aortic dissection. So here we see dissection starting on the inferior aspect with some extension in the retrograde manner. And so she was dropping her hemoglobin. She went on to have a TIVA. And here we could see as the scan progresses, you would see the stent all the way up to the left subclavian, and that extramural, the false lumen has been sealed off. Next case, this is a guy, a 52-year-old man, uncontrolled hypertension. You can see that there just by his arch anatomy as that bird beak appearance, everything becomes distorted, presented with chest pain radiating to the back. So he went on to have a TIVA, excluding that large false lumen. He's one of those guys that had that sort of slit lumen type pathology. There is a remnant dissection in the abdominal aorta, which we have under surveillance. But at least for now, we've got him out of trouble with respect to his rupture risk of that thoracic aneurysmal degeneration. And my final case would be, this was a 50-year-old man who presented with central chest pain, was found to have, this is what we call a penetrating aortic ulcer. So here it was probably like 1 millimeter defect here for, sorry, 1 centimeter defect, 10 millimeters. And it was 2 centimeters in terms of longitudinal length. Then 1 month later, it rapidly increased to probably 4 by 5 centimeters. So with this rapid progression, his only option was to have a TIVA or open surgical repair. So he had a TIVA, and that's excluded that area of that penetrating aortic ulcer. So in conclusion, what we can say is that endovascular intervention on the aorta remains an invaluable tool in the management of both thoracic and abdominal aortic conditions. Open surgical repair for the abdominal aorta remains the predominant method of intervention for us compared to thoracic intervention, which I did touch on earlier, which the endovascular method dominates. In keeping with the theme of this meeting, I think we need to have further collaborative efforts within the region, as well as with the industry leaders, to facilitate and promote the increase the number of endovascular interventions performed on the aorta. These are my references. Thank you.
Thank you very much, Dr. Pran. Do we have any questions before Dr. Pran? Let's go.
We work closely together during training, obviously, but for the last several years, just trying to help him expand the endovascular program here in the Bahamas. So I'm very curious, we've had several situations where patients died waiting for grafts. I'm curious to know kind of your experience, and then what's the turnaround? What vendors, what distributors, are more receptive? And also, separate question is, if you're doing TVARs, what is the barrier to doing EVARs instead of open surgical aortic repair?
Right. So all of those are very, very good questions, and I think I have the answer for all of them, which is also good. So, with respect to our approach, being obviously, if a patient comes in with a transected aorta, if we have a graft, we stent the patient. Most times we don't have a graft, so therefore our management strategy is blood pressure control. Get the patient into the HDU. Make sure we have blood cross match, etc. Get the thoracic surgery team involved as well, plus or minus cardiac surgery should we have to take the patient in open. And from there, it's then fast track letters, approvals to the administrators to get them to say that they are going to purchase a graft, because none of the RHAs nor the company has the grafts on the shelf. It's very rarely they have the graft on the shelf. So once we get the approval or the promise to pay, we then send that to the company. The company then locates a graft and then ships it in the country, which all of this process may take us. The fastest we've got a graft in the country probably was 2 weeks. Yeah. Which, during that time, anything can happen. So we've had patients who waited up to a month or 6 weeks in hospital just waiting for a graft. Now, what we have seen is that most times, once the patient survives, meaning that initial insult, and we're able to manage their blood pressure, etc., most of them hold. The exception to this rule was, there was a patient last year, which he was in that situation, comes in with a transected aorta, 40-year-old man. We did not have a graft in the country, tried to get the graft, and the day the graft got into the country waiting for clearance, he ruptured and he exsanguinated in the ICU. So in terms of if we don't have a graft, we have to rely on the patient surviving or defining themselves essentially to enough or for long enough for us to intervene on them. With respect to suppliers we have available, so we've tried to engage other suppliers like Geotech. But as I said, Medtronic is the most common one. The problem is, because our requirement is so low, we don't have, let's say, a designated supply of grafts, because obviously the big buyers, the grafts will go to them automatically. Kind of like what happened with the COVID vaccine. So So that is why what I am trying to do now is that because we have what we call 4 regions, and we are the only public cath lab or only lab that we are able to do these stenting, and I'm trying to get each region to commit to buying 1 graft. So that way, because they're all going to be done in one center, we have 4 sizes, and just using those 4 sizes, technically it could fit any patient that presents with such of a problem. But understanding that these 4 regions, they have their own budget, and their own, they some of them they are agreeing, some of them are not. But the big problem is when we have these patients, they come in and we don't have a graft on the shelf.
Have you looked into consignment? Like maybe not just for one country, but some sort of centralized consignment that's kept somewhere in the Caribbean, so nobody has to prepay it. It's consignment. It's multiple countries, so there's motivation for a vendor. And then you could potentially ship overnight to another country if needed.
Yes, I was actually looking for the Medtronic rep. That was Nichelle. So we have had conversations about this with Medtronic, and there's an office in Puerto Rico, which is where we sort of kind of agreed that okay, we will have these grafts there, and once, because Puerto Rico to Trinidad has probably as you mentioned, an overnight ship, so it comes in quickly. And I think that after this meeting, both Lucas and I, as well as the guys from Jamaica, we have to seriously sit down and come with a firm agreement amongst us, and as well as Nina from Barbados, because she's having a similar problem, meaning that this is what we're gonna do as a region with respect to this particular problem. So I take that piece of advice, very, very strongly. Yes, Nichelle. So we have a colleague here from the US, and she's trying to help us, work through our problem with getting grafts, meaning endografts, in Trinidad, Jamaica, Bahamas, because, patients have died waiting on a graft. So I was telling them that we sort of had a meeting, I think it was last year, with the regional manager, and he agreed that they would consign grafts for us in Puerto Rico, and once we need to get it shipped. So what we are trying to say is that we need to sort of get that going, because
So you're with Medtronic. Oh, okay. What's your name? Nice to meet you. Hi, I'm Julia. So is the barrier to getting grafts this process of getting a graft? Is that why the abdomens are being done open mostly?
No, so that is one barrier. The other barrier is the cost. So the cost of a graft in US dollars, so a TIVA graft is probably about 10 to 15,000 US.
Yeah.
That translates anywhere between 70 to 100,000 TT dollars. So administrators, they find it very hard to put out that what we call a direct cost to fix an aneurysm, when Pran could just go in the theater and do it open, and there's no direct cost. They're all just indirect costs. The only direct cost would be the cost of the Dacron graft, which is probably 5,000 TT. Yeah. So
there's the cost of like the ICU stay and all that stuff. Right?
Yeah, agreed, 100%. But those administrators, they don't see it that way. They see all those as what we call indirect costs. But what they are concerned with is the direct cost of purchasing that stent, and that is a big barrier to getting endovascular stents. And but when it is you have a patient that you say, if we don't do something, this man is going to die, we kind of push them to they're back against the wall, and they have to purchase the stent. So that's where that sort of scenario, that is how it has evolved for us in terms of how it is we practice. Any more questions?
Thank you. Thank you, Dr. Pran. That was an insightful presentation. I think it's so exciting to see all of this integration from a Caribbean standpoint, and how the University of the West Indies has brought so many of us together. Similar to what Dr. Notch said, that we went to school at Mona together as one of the first female general surgeons coming out of the Bahamas. I also went to school in Trinidad for pre-med with Dr. Bodie, who was probably my first Bahamian friend. And again, watching her become again one of the first female Bahamian surgeons in our country. So it's just really been so beautiful to watch, and seeing all this innovation emerging across the region. It's very inspiring. So our next speaker Dr. Ran Ilyas began his medical training at Semmelweis University, graduating with honors in 2008. He completed his training in internal medicine and adult cardiology at Hadassah University Hospital in Jerusalem, followed by advanced work as a specialist in interventional cardiology, acute cardiac care, and research. He went on to complete a cardiac interventional fellowship at Sunnybrook Health Sciences Center in Toronto, and later helped establish a standalone cath lab in New Zealand. Dr. Ilyas now serves as a cardiologist and interventional cardiologist at Doctors Hospital here in Nassau. He has contributed to several major international studies and is co-founder of CardioVia, an FDA-approved device for interventions on the surface of the heart. Please join me in welcoming Dr. Ran, as we all call him, who will present an update on coronary revascularization in the Bahamas. Dr. Ran?
Hey, thank you. Thank you so much. Warm welcoming as always. This is the place to be. I got my, put on my, I brought a backup. I always bring backups. Don't have any stents on me, but I always bring backups. Sorry, Medtronic. By the way, I wanted to ask, meanwhile, did you ask China, India, other places? Because they have devices. I know there's a lot of debate, but as far as coronary stents, Hercules. Yep. 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 Because I think we're in a kind of unique environment where the rules that govern us, we can be very flexible. I know that from Israel. You could take the guidelines both ways, and you can enjoy other devices that were fast tracked. And today, with all respect to, we all like our go-to workhorses and stuff like that, but we should be looking at other places and what they're doing as well. I can tell you in coronary imaging, for example, the IVUS and OCT catheters that we use in cardiology, I would prefer using a Chinese brand today. They're better, they're cheaper, and comparable. So, just as a thought, hopefully I didn't step on anything, fingers to say. I'm fired, right? Yeah. I knew it. Anyways, I'll start. Can you see it? All right. Yeah, cardiovascular team. Self-explanatory. We're working together. This is, poking a hole with a micropuncture, getting a wire up, and using it for whatever intervention we need. This is what we should all be doing. And I'm going to go quickly through this, which is, again, this is very obvious, effective multidisciplinary discussion, management of CAD and PAD. They go hand in hand. And today we have excellent tools. We got excellent imaging tools. We've mastered most of the first steps of getting the diagnosis in a timely manner, making the correct diagnosis, and offering the treatments. The hardships are, and you mentioned that, is the cost, is the availability of equipment, but that, I think, pushes us to be more innovative. And if we can't get it one way, we need to figure out other ways. Sometimes it's compassionate treatment. Charles is my go-to person when I need to, get things done at a matter of sometimes minutes. And numerous phone calls of patients that are crashing now. We need to find some solution. We need to find something to do to help them out. By the way, I know traumatic aortic transections, dissections are a big thing, but I've seen a fair share, for the last year, I've been working a fair share of young people coming in with, hypertensive emergencies with type B dissections and stuff like that. So there's no doubt a huge population that we're not capturing as far as aortic pathology and coronary pathology as well. And this patient this patient I'll present is a showcase. So actually, why do we need to combine? Because we know obviously PAD and CAD go together. And what is some parts of our evaluation? We all do this, in the clinic and outside the clinic as well. Complex CAD usually carries a heart team discussion. But what about the vascular, our vascular colleagues? What about discussions about the vascular system? What about checking for vascular, for PAD? We're kind of soft on that end. And I think today when we speak about terms like limb salvage or limb mortality, that's gaining a lot of debate and a lot of credit when we were able not just to save a patient from MI, but also to save a patient from limb amputation and from other complications, which today we know that lead to very high morbidity and mortality. I think the complex lesions that we see in multi-vessel CAD, left main coronary disease, and the necessities for surgical or open procedures, CABG being the mostly performed, that's been established and set. But sometimes we need to be more creative. Sometimes the patients don't want to have surgery. Sometimes the patients can't have surgery. Sometimes we need to think outside the box. And I think to think outside the box, you can't be doing it on your own. You have to have a team with you. It's not only, working together with vascular and cardio. It's also having anesthesia. It's also having ICU. It's having all the other people that I might forget sometimes that support me in that system. It's medicine, it's endocrinology, it's wound care. The list goes on and on and on. And just as we talk about these teams that should be sitting together and collaborating, it expands obviously, and it grows, and the list grows on and on. I think, okay. So I think to showcase this, I'll just present a case that we had just last week. So this is a 68-year-old female that came in with critical limb ischemia. This is not her foot, but her foot was not far from that, or maybe even more advanced than that. She's been having intermittent claudication for months. She had also shortness of breath for months. But what happened was she stopped walking because of the foot. So she had angina equivalent, but she wasn't active. So she wasn't feeling angina at rest, obviously. But asking her, getting the history from her, you do understand that she's definitely slowed down. She definitely was having symptoms on very minimal exertion. She never had any cardiac evaluation. Came in now with critical limb ischemia. What do we do from here? So the vascular team, very rightfully, did all their planning in terms of endovascular procedure, trying to do some limb salvage procedure to prevent amputation. But during that, also evaluated for cardiac comorbidities. So her ECG, very interestingly, did not show what we were expecting, or at least I was expecting to find, which was probably significant poor R-wave progression, Q waves in the inferior wall. That's all the stuff with T wave inversions, all the stuff, it's ST depressions, all those wonderful things we see with multi-vessel coronary disease. I was expecting to see it on her ECG. I didn't bring a picture, but her ECG was actually better than mine. So it didn't show anything. So that's one part of a caveat that we encounter sometimes. And today the guidelines speak about enzyme testing. They speak about BNP testing. And I think we started doing this for some of our patients, the high-risk patients. We started doing these screenings. The problem starts when they have renal failure, so they'll have a positive high-sensitivity troponin. BNP is subjected to all kinds of different changes. How do we interpret it? What do we do with the results? That's the whole showcase of a team. So we call the cardiologist at 12 o'clock at night telling him he's got a high sensitivity of 500, and the cardiologist says, well, I'm going to cath him. So that's the usual response. But well, for me, her labs were actually quite good. So she had normal renal function, but the hemoglobin was for chronic reasons. The next step was to do an echo. Okay, we obviously there was significant concerns with the anesthesiology team, vascular team. Don't want to take a hot potato like that into surgery, and she arrests or has a VF, and then when the fire is out, then you're scrambling to call you're scrambling to put out the fire, and that creates a lot of difficulty. So her echo showed us a significant problem. Her EF was 30%, so severely reduced LV function with, interestingly, an anterolateral hypokinetic wall. And that's why we did not see anything on her ECG, because it's the back wall, the circumflex, the hidden artery. ECG sometimes looks normal, but the echo told us a whole different story. And the angiogram will tell us a different story. So that was her echo. So now, from a complex patient to a very complex patient to a very, very complex, high risk in mortality and obviously morbidity patient. So what do the guidelines tell us when we talk about the plan? How do we proceed? What do we do? What do we do with all this information? Because now we're having difficulties. We can't take her down to theater. It's surgery. It's going to be even more complex. What about medications that we want to use? What are her risks? How do we risk stratify this patient? She's way off the charts. So, and of course, the high morbidity and mortality. So, not surprisingly, class 1 indication was to have a multidisciplinary team, and that's exactly what we did. I get a phone call from Dr. Johnson, Dr. Lucas, telling me about the patient, telling me about the findings, telling me about the echo, and then we start sitting and formulating a plan. Okay, so what do we do? What's the next step? Thank God she had normal renal function, but even there, even if she had renal failure, that the next step would be coronary imaging, right? Because no one wants to leave that rock left untouched. And the 2A indication, which is a very high indication to proceed also with endovascular or even surgical resolution of her foot, because again, for the same reasons, mortality, morbidity, which are highly increased. So we did the first step, we did the second step, anesthesia, surgical team, and the third step would be the guideline-directed team approach, which is actually the cardiovascular team. And the guidelines support all this, and in terms of the steps that we've taken. So, and you see a class 2B indication. Interestingly, the guidelines from 2024, AHA guidelines, have stated there's no benefit undergoing, when patients undergo non-cardiac surgery, to have routine preoperative invasive coronary angiograms. I know that maybe even 10 years ago, there was a hype. There was a lot of angiograms being done on these patients. It's part of the planning towards these procedures. And we were stenting because that's what we do. We love stenting. So we were stenting all kinds of small lesions, which we're not sure about their significance. And I'm not talking about left main, proximal LAD. I'm talking about distal vessels, talking about side branches, talking all kinds of stuff. Now, and that's what I always tell, the trainees and students and colleagues. Once you put that stent in, you're committed. Especially the first year, you're committed, because stent thrombosis is a huge problem, and complications might happen during the procedure itself. So this is not stuff that we take lightheadedly. And even though we love, we have a lot of stents on the shelf, coronary stents, and we love using them, but we have to use them judiciously. So that's just something to remember. Now these are the original pictures. Sorry, I took it with my phone. We have a new system Doctors Hospital, brand new cath lab, just opened up 3 months ago, and we are doing procedures there. So fully capable of doing endovascular procedures as well. It's a Philips system. It's brand new. So these are some of the images you can see on the images. The images are playing the pictures are playing. It's the right coronary artery. It was small. It was diffusely diseased. It had an 80% lesion in the mid portion. But the money shot was this thing here, and this is the left main, and this is LAD. And you see an aneurysmal positive remodeling segment, but you see also about a 50% narrowing in the body distal part of left main into the ostial circumflex. So it was hanging by a thread, and it's not maybe it is kind of apparent from this image. But when I took those images, I was like, oh my god, this lady dodged a huge bullet. Putting a lady like this under on general anesthesia, blood pressure drops, coronary perfusion drops, you get VF, you get asystole, and not much we can do to help her at that point. When this starts blocking up with thrombus, even for me, it will be hard with the equipment we have. She also had a mid distal stirk lesion, but you see the main lateral posterior wall is supplied by a huge circumflex artery. And that was her problem. That was causing her dysfunction and the echo. And at this point, okay, what do? We got the answers. Do we stent? Do we send her to cabbage? What do the guidelines tell us? Well, the guidelines talk about the syntax score, and her syntax score was high. It was over 24. It was well over 22. We know the trials have a benefit for cabbage in these patients. So I was like, okay, this is going to be a headache, because now we got critical limb ischemia. We got a lady that needs urgent care of her limb because she's going to have major complications. She has major significant coronary arteries involving the left main. She's a diabetic. She has poor LV function. These three alone push her towards cabbage, push her towards surgery. So I hold the procedure and I start doing a round of phone calls. I call Dr. Lucas. I call everyone that's involved. I call the cardiothoracic team, Dr. Sands, Doctors Hospital. And I don't, at this point I'm thinking, what is the evidence-based medicine that I should be acting on? What does the patient want? What does the patient's family want? And how do I present all these findings? And how do I get a resolution right there and then on the table? Do I have to get a resolution right there and then on the table? Some of you might think, no, take her off the table, have a discussion, bring her back for, whatever you decide. I felt that at that point, if I don't do something, we're going to miss that train. This lady has dodged a first major bullet. I don't think her body will take a second heat. This is my thought. This is my personal gut feeling based on X years of experience that I have. So what I do is I speak to CV surgery, I speak to vascular surgery, and they say, well, if you feel, we understand the problem. She's between a rock and a hard spot, basically. If you feel you could stent it fairly safely, you can get the procedure done, you should present it to the patient and have the patient decide whether or not she wants surgery or PCI. I go back to the patient, I speak to the patient, I bring the patient's daughter with a video conference call inside the room, in the cath lab. This is for an hour. We're all sitting there with her daughter. We dressed her up. I explain the whole thing. I show her the images, the family. She has, I think it was a boy and two daughters. They're all on the phone. Her granddaughter's on the phone. And the patient says at the end, stent it. And I asked the family, okay, listen, stenting means high-risk mortality, too. This is over 10% mortality in a procedure like this. Left main, poor LV function, 68-year-old patient with a biological age, which is well over 68. And we decide to proceed with stenting. We take all the precautions. Obviously, I notify the vascular team. because other things might happen. So anesthesia was down there in the room, ICU was down there in the room to give the support if needed. She did not need any support around, so she was stable, hemodynamically stable. She did not need any supplemental oxygen. She was pretty comfortable in terms of pain. Her leg was actually hurting her. She did not have any chest pain at this time. Sometimes these patients have chest pain just by taking the images. And this is what it looks like after we stent. This was not an easy procedure, to say the least. What I managed to do was to balloon, POBA, thank you, Grunsig, POBA, balloon dilate the distal. I started with the distal circumflex because I did not want to treat the proximal. If I get that messed up, the whole thing will go down. So I wanted to get some distal flow, so I ballooned the distal portion of the circumflex. That's what it looked like. But this was the main bulk of the work. We tried a few balloons. We tried to pass a stent. It did not go. We ballooned it again. Blood pressure went down. Became bradycardic. Things became a little bit tense at that point, but eventually we managed to get a 3.5 millimeter stent in there, 3.5 by 20 millimeter stent. We covered from pretty much the body, the mid body of the left main, well into the circumflex. Remember that angle before that was well over a 70-degree angle, which is not ideal for stenting, but thank you, Synergy. Their stents are, I don't know how they did it, but they delivered great, and this is what we ended up doing. Patient was feeling great. She was ready to jump off the bed because she had enough time lying down. It took us like 3 hours with all the talking and everything, but the procedure itself did not take too long, the left main procedure. And I was very, very happy with this result. We gave her Brilinta as an antiplatelet and aspirin. We put her on heparin, and I think this probably showcases what we're able to do when we share, our experience, when we just join effort. And I think the same goes for aortic stenting. I don't think that no challenge is too big. I think if we combine forces, I think we can do remarkable things, and I hope this lady will recover. I'm pretty sure her myocardium will recover. A lot of it is hibernation and stunning. And I'm very happy we had this chance of collaborating and joining efforts and hands here. And I think ad hoc teamwork is really important. We should do it all the time. And we should do it all the time, even for the toughest of cases. We should not make decisions based only on our personal experience or thoughts that what could have happened. We should always hear other people and hear their perspectives. I learn something new every day from my colleagues. We should know our friends. We should know our enemies, but we should know our friends. Good imaging is key. Don't compromise on good imaging. Imaging is the key. When I do diagnostic angiograms, I never compromise on imaging. And if I need to pour another 60 cc's of contrast, I will do it. I will give hydration. Sometimes we risk with kidney irritation, but imaging is everything. Any step you take, if your imaging is not good, you're going to be in a whole world of pain afterwards. We need to think outside the box, and again, call, don't fall. That's probably my best take-home message. That's it for me.
Thank you very much, Dr. Rand. Do we have any questions for him? Any questions? Was it that good? Yeah, great. Thank you. I know it was. Thank you, Dr. Rand. So that was an excellent presentation. And thank you for all your work in advancing care when precision and intervening matters most, right? So we now turn our attention to the evolving landscape of cardiac electrophysiology. And our next speaker is Dr. Rojal Morris. She is an internist, an adult cardiologist, and cardiac electrophysiologist who completed advanced fellowships in adult cardiology and electrophysiology at the University of Toronto, Canada. She's passionate about strengthening cardiac care systems across the Caribbean through clinical and regional capability are reshaping the way we understand and treat cardiac rhythm disorders across our island communities. Dr. Morris, are you there? Do we have her? Okay. Oh, you're muted, Dr. Morris. We can see that you're there, but we can't hear you. Yes. Yes, we can hear you now. Welcome. Oh, you can't hear us. Yeah, she can't hear us. Can you hear us now? Okay. Okay, you can go ahead because we can hear you loud and clear.
Okay. So let me just end this here and just do a regular slideshow. Okay, so today I'm just going to take you on a journey of what EP really means and what we've been doing at Princess Margaret Hospital. And then I'll take a look at perioperative arrhythmias and what the surgical teams should know about perioperative arrhythmias. So I have no disclosures at this time. So I'll give you an introduction to what electrophysiology is. A lot of us probably know by now what that is. Take a look at some of the precision therapy that we've been doing as it relates to atrial fibrillation ablations and how we've been doing using minimal hybrid ablations and doing atrial clips and what that is, and look at why perioperative arrhythmias matter and what common arrhythmias we see in patients who are going for surgery or may develop perioperatively. And then what are the management pearls as it relates to anticoagulation and when to call the cardiologist. And just give you a brief case example as well as take home messages for today. And then I'll entertain any questions and we can go through a bit of a discussion. So EP, or my colleague Dr. Elias did an excellent presentation on a branch of cardiology that we consider to be invasive, but is actually minimally invasive. He deals with plumbing while I kind of deal with the electricity, and he had some excellent cases just now. The last one was a bit nerve-wracking, but happy that he had an excellent result in terms of stenting the left main coronary artery. For me, my EP procedures deal with both fast rhythms as well as slow rhythms. For the slow rhythms, we tend to obviously put in pacemakers. So we do permanent pacemakers, whether that be single chamber or dual chamber. We can also do loop recorder insertions, which is just a very tiny device that can go under the skin that can help in terms of diagnosing arrhythmia. We also do catheter ablations for atrial tachycardias or atrial arrhythmias, as well as for atrial fibrillation. We can also do temporary pacing procedures, which is quite minimally invasive. And the reason why we do that is the reason why minimally invasive surgery was developed in the first place. It was mostly for precision therapy, minimal tissue disruption, faster recovery, and have improvement in outcomes. So at PMH, we actually kind of started somewhat a pacemaker program. So from last year, October till now, we were able to implant 10 pacemakers. So myself and Dr. Lucas, who was closely working with me, mostly for vascular access and with also closure of my small wounds, we implanted 8 dual chamber pacemakers, and these were mostly for patients who had complete heart block. There was one patient who had a device that that was at end of life, and then the other 2 dual chamber pacemakers were for patients who had concomitant atrial fibrillation and just required a VVI pacemaker. And these were all successful. In terms of state-of-the-art hybrid ablation, recently there has been this robotic-assisted hybrid atrial fibrillation ablations along with atrial clips. So it's state-of-the-art minimally invasive treatment for a persistent, long-standing atrial fibrillation. And it combines both robotic epicardial ablations along with your endocardial catheter ablations, which are usually done by the electrophysiologist. And then with this, we are able to develop comprehensive transmural lesions, which hopefully will decrease the patient's chance of having atrial fibrillation. And the other thing will also improve their freedom from atrial fibrillation as well. And the added benefit is that with atrial clip, we can actually do that to close the left atrial appendage, again, to reduce the risk of developing atrial fibrillations and also minimize stroke risks as well. So this was just a study that was done at the Medical College of Wisconsin, where they did robotic enhanced hybrid atrial fibrillation ablation for persons who had long-standing AFib. And they took 64 patients between January of 2021 to June 2023 and looked at what their rhythm follow-up would be after they had done hybrid AFib ablation. So of note, which is to me quite high, their freedom from AFib after 3 months was 73.4%. For most patients who have endocardial ablations, which the electrophysiologists do, most times their freedom from AFib can be somewhere between 50 to 75%. So to have a good outcome like this with freedom from AF, I think robotic enhanced hybrid ablations will be something that we will probably be doing more in the future. So usually it's a multidisciplinary innovation, as you can see, and it has given the option for patients who have complex atrial fibrillation, so long-standing, persistent. Sometimes these are patients who have already had endocardial atrial fibrillation ablations, and it didn't work. And therefore, having this option to do an epicardial ablation as well has to somewhat intersected surgical and electrophysiology to some extent. So why do arrhythmias matter? And we know atrial fibrillation as an arrhythmia has been quite a problem for a long time. Perioperatively, especially for if you're going to be doing minimally invasive surgery, it can have a significant impact. So it could result, because essentially you do minimally invasive surgery to have a shorter hospital stay. If you develop perioperative arrhythmias, it may get your hospitalization quite prolonged. You can have an ICU stay as well. Patients can become hemodynamically unstable. There's also a stroke risk, especially for patients who develop perioperative atrial fibrillation, dependent on what their other comorbidities are. And then again, you have a delayed recovery, delayed discharge, and overall increased healthcare costs. So the most common perioperative arrhythmia, as we know, is atrial fibrillation, but there's also other arrhythmias, including your SVTs, bradycardias, premature ventricular ectopy, or even non-sustained ventricular tachycardia, or even ventricular tachycardia as well. And then, of course, the most common tachycardia that we do experience is sinus tachycardia around the time of surgery for more than one reason. It could be related to blood loss or decrease in fluid management. So you have common triggers, which could be your sympathetic surge, pain, anxiety, hypoxia, electrolyte disturbances, blood loss, inflammation, even sepsis or fluid shifts, or even if it's structural heart disease. So there are usually four key questions I ask myself when I have a patient with a rhythm problem, and this is something that you should probably keep in mind. And the first one is this patient stable or unstable? And, what is the rhythm? Is it sinus or is it an atrial arrhythmia or a ventricular arrhythmia? And then the next question I ask, usually, especially if it's surrounding surgery, is this a reversible cause and what is the trigger? And does it require urgent treatment? So for the unstable patient, obviously, we want to do urgent treatment. And most times our red flags will include hypotension, chest pain, pulmonary edema, if they develop altered mental status or they develop shock. And the next action, of course, is to do urgent synchronized cardioversion, especially if it's a tachyarrhythmia, and that's quite appropriate. For stable atrial fibrillation and SVTs, obviously the management, you can focus on looking at other things, including triggers. If there is an issue with pain, you will give analgesia. Are they hypoxic? Do you need to give them oxygen? Do you need to replete electrolyte disturbances? Is it a case where we just need to rate control because they've had an underlying history of atrial fibrillation from before? And then if in select patients, usually this is quite rare to do, whether or not we need to do rhythm control. And then obviously ongoing monitoring and assessment and follow up with a cardiologist if needed. For bradycardia, most times it's related to medications that we may give around anesthesia. The patient could also have a high vagal tone, or it could be related to ischemia, especially if it's a right coronary ischemia, or they can have underlying conduction system disease. So usually you would, again, review any triggers or review medications and give atropine if necessary, and if there is a need for temporary pacing, if the person has complete heart block or persistent bradycardia that is irreversible. When it comes to anticoagulation, usually it's for patients who have atrial fibrillation. The key question is, I usually ask is actually what their CHAS-VAS score is, along with whether or not this is persistent atrial fibrillation. And then I go on to identifying with the surgical team what their post-operative risk of bleeding is if I'm going to be starting anticoagulation, and when will be timing to start that. Obviously, the best approach is to have a shared decision making between surgical, medical, and the cardiology teams to determine what will be the best plan of action. So usually I say call cardiology whenever you have this small inclination to. I have a low threshold to be called. I have no problems being called. But if you have somebody who has persistent atrial fibrillation, which is newly diagnosed, if they have a recurrent SVT, if they have a wide complex tachycardia, because it could be a supraventricular arrhythmia with aberrancy, or it could be ventricular tachycardia. If this person has suspected heart block, if there has been syncope, refractory symptoms, and if there is some diagnostic uncertainty. So we have a 72-year-old gentleman who went for laparoscopic cholecystectomy. His heart rate was 148 and it was irregular. He described his pain as 8 on 10 after his cholecystectomy, and his potassium was 3.2. And I think the most likely diagnosis was probably post-op atrial fibrillation. I'm not going to go through too much on post-op AFib, but essentially the ECG was done. It confirmed atrial fibrillation. And I think one of the key things is that we needed to replace his potassium and magnesium, and then ensure that he had adequate pain telemetry to see if this was in fact just persistent or if it was paroxysmal, and then reassess the need for anticoagulation based on what his risk factors were. So the take-home message here is that remember EP is a minimally invasive field as well. Arrhythmias are very common around surgery, and you should always identify what the reversible triggers are and very early so that you can minimize them going forward and also minimize time post surgery. Unstable arrhythmias usually require urgent action and teamwork. Again, something that my colleague, Dr. Elias, just pointed out, teamwork improves outcomes. So thank you so much. And I'll take questions and any discussions, but I can't hear you guys. No, we can hear you.
Thank you, Dr. Morris. Do we have any questions in the room on her presentation? Yeah. So for those of you who are in the room, lunch is being served. You can feel free during the presentation from our rep from Ports that you can go ahead and eat. We have no issues with that here because we are running a little behind, okay? So feel free. Okay, so no questions for Dr. Morris. Thank you, Dr. Morris.
Thank you. Take care.
Thank you. Okay, so our next presenter is Dr. Andre Ramdon. Is he here? Is he online? Dr. Ramdon. He's not online. Okay, all right. So we don't have Dr. Ramdon at this time. Thank you again, Dr. Morris. Really insightful presentation. We all enjoyed it. And so we're going to go straight to the Ports rep. Her name is Miss Catalina Arenas. And so she'll just speak to us quickly for about 5 minutes and we can all grab our lunch. Then we'll be back with ortho. And thank you again to all of the cardiology persons represented. We really, really appreciate it. Thank you. For those of you online, we're just getting connected with the rep. Okay, so she's ready to go. We will be up and running in another 1 or 2 minutes. So feel free to grab some water and your lunch if you're at home or in the hospital.
Okay, thank you. Okay. Hi everyone. Good afternoon. I hope you are enjoying your meal. Thank you. Better? Okay. My name is Catalina Arenas. I'm from Colombia. I work at Medtronic. And just a small thing, as you can notice, I am not a English speaker. So my first language is Spanish. I will do my best to speak clear, but are if you have something that you are not understanding, feel free to interrupt or ask or something. I promise I will do my best. Okay? So as I said, I work for Medtronic. I have been already almost 8 years in the company, and I love balance, traveling, cooking. She's my travel buddy. That is my sister. She's my sister. I am based in Bogota, Colombia, and I was born in Manizales. It's a small town in Colombia where the best coffee is made. Okay, so today I want to talk to you about the role, the key role that industry has in all the way for transforming the surgical approach from open to MIS. Okay, this approach matters to Medtronic because our philosophy, our mission is to put the patient first. And of course, the minimally invasive surgery, it's aimed to have better outcomes in patients. But despite the clear benefits of MIS approach, the adoption is not uniform across all the regions. Just to give you an example, in LATAM, we are estimating that in colorectal procedures, for example, just the 25% on average is performed by MIS approach. So it means that we have an opportunity of 75% in open surgery to transform to or to migrate to MIS. Not always the open surgery or the low penetration of MIS approach is related to technology. Sometimes it's lack of education, training, experience, and also exposure to MIS environment. So our role in Medtronic is to give or to help to support the healthcare systems and the surgeons in that transition. Okay, so we have some programs and some tools in order to support the MIS approach. But we do know that moving from open to MIS approach is a journey. It's not a single event. It's not just a proctoring. It's not just a master class. Okay, so we know that requires progressive skill development, mentorship and proctoring, team-based training, and these programs must be structured, continuous, and aligned with the surgeon experience. So we have some programs to support that. And these programs, the focus areas of those programs are deliver access to high quality training and education, innovate resources designed to inspire excellence patient care, have pathways, standardized pathways of learning, and have contact with global expertise and exchange the knowledge. For example, we have some agreements with IRCAD in Latin America, also in US, just to support surgeons to have contact and knowledge from surgeons that are KOLs in our regions. And our goal is to support surgeons and institutions, of course, without replacing clinical judgment. Are just tools to support, but we are not an academic institution, but we are the bridge. so you can take advantage of that. And what is our educational philosophy? Patient-centered approach, as I said before, surgeons' skill development, experience-based learning, long-term development, not isolated courses, as I said, and focus on outcomes, consistency, and sustainability. That is our focus. So we have already a pathway. This pathway is regarding segmentation that we already have of surgeons. So, for example, we have here our first segment are the surgeons that are starting their career. And we have some programs in order to increase and encourage the practice, the early practice and basic knowledge about MIS approach. Then we have the segment 2 that are surgeons that already have had exposure to MIS approach, but they need to practice. So we have here another programs to that group of surgeons. And then we have the segment 3, is the segment that is where surgeons need to enhance their skills. So we have here some programs even longer that the programs that we have for the two first segments to enhance the practice, right? For MIS approach. So we have here mainly a program that can be a 2-year term program, okay? Here we have the segment 4 that is already a rising star. So here the pathway is short because maybe here the skills that the surgeons already have are high, but probably what they need is more like a professional skills, communication skills, how to become a key opinion leader, okay? And here we have the surgeons that are already key opinion leaders, and we want to develop some skills as trainers in order to train, again, all the segments. So you can be in one segment of this, and we have a program, to develop your skills. If are technical, or if are communicational, or maybe if you want to be a teacher. Okay, is clear? Okay, thank you. Also, as I said before, we have some agreements with IRCAD in Latin America and also in North America, in US. It gives you access to global experts, high quality surgical content, best practices in MIS, and of course, you can go as you want. I mean, it's a self-directed training, so you can go directly to the, for example, in this case, a colorectal base camp, and you can explore all the content that they have for colorectal surgeons. And it's for free, it's free, you get credits. And we have another tool that is Medtronic Academy. It's a platform, it's actually, I forgot the word, yeah, a web page designed to empower healthcare professionals and their learning journey. And we have here all the Medtronic portfolio. So you can go through stapling, surgical innovations, vessel sealing, but also cardiac surgery, also cranial and spine. All the portfolio is in Medtronic Academy, but also webinars with other surgeons about specialties, content about specialties, about procedures, all the things that you need as surgeons. This is also available for all of you for free, just in the time that you can do it. And here is on, as I said, on-demand courses. We have procedural insights. Also, you can find clinical evidence and educational resource. And yeah, you can navigate through all of those points. Yeah. Okay. And so, as I said before, successful transition to MIS requires technology, but not only the technology, education, partnership, and that is what we want to build, partnership, especially with you, with the Princess Margaret Hospital. We want to be a partner in order to increase the MIS approach. So count on us, okay? And Medtronic supports hospitals by creating structured learning ecosystems, connecting surgeons globally, and supporting long-term clinical excellence. And as I said, this is the opportunity to strengthen MIS adoption, develop internal expertise, build sustainable education models, and I will be happy to share with you all the programs that we have. If you are interested, just reach out. Okay, this is the presentation. If you have questions, suggestions, congratulations. Thank you for the invitation. It's for me a pleasure to be here.
Comment from Dr. Lucas.
So I just want to say thank you to Medtronics. Having been fellowship trained, you come home, you practice on a lot of products from your competitors. I won't name them in this forum. And I remember looking at the endovascular magazine and contacting, it was like 100 and something. I contacted 99 like distributors and manufacturers. I got a response from about 10 and a favorable response from 0. And then even looking at what was available, a lot of the major players pulled out to the region and no longer supported the products that we were custom using. I think Medtronic was the only one who had the Arctic stent, and I think Dr. Pran has a similar experience. And if I have a difficult case, we don't have the reconstructive software to sometimes look at the aorta and plan. Medtronic has been there to actually help me plan our surgeries and then provide the stents in a timely fashion with the limitations of our geographic location. And we want to really work more closely to get these things faster. And I'm hoping if we behave well, we'll get some sort of consignment as well going forward. But thank you again for your support. And Dr. Grimes, I hope our residents can take advantage of the educational offerings and the partnerships to really develop some opinion leaders and transformative leaders in the MIS space. Thank you so much.
Thank you, Dr. Lucas.
Hi, thank you for the talk. In addition to the online modules, are there any setups where we could practice as well? Okay.
Actually, we have a pathway for MIS approach called Guided Learning Pathway, or GLP, not GLP-1, but GLP. And it's a complete pathway to increase the adoption for MIS approach. So it starts by selecting some faculties in the area or in the hospital, and we train those faculties in soft skills. And then those faculties are going to train a group of trainees, of course, by performing a master class and then a preceptorship in order to see the faculties how they perform the MIS surgery and the standard process of the surgery, and how to have a proper debrief of the clinical history of the patient. And then the pathway has a complete pathway for mentorship. For example, for colorectal, the trainee must perform at least 8 procedures with the faculty. And then the faculty is going to review, after the mentorship phase, is going to review by video how is the trainee performing by himself the surgeries. And he's going to give feedback to the trainee. And then the faculty is going to say, Medtronic, yes, he is already ready to perform just by itself the procedures MIS or not. And it's a certified program. It lasts around 1.5 years, but it's face-to-face, it's one-to-one training.
Through my own, with my own spine journey, and I was talking to Dr. Lucas when he came home and remains very enthusiastic. Is how do we get a big company like Medtronic to be interested in a small country like the Bahamas, and how do we get access to all that you have, but without the North American costs? Because I'm always interested to talk to my Caribbean, Latin American colleagues, because the same thing in Latin America costs a lot less than it does in Miami or New York. And so, and the issue for us is we want to implement things. We have surgeons now who have the skill set and who are enthusiastic about implementing these things, but how do we allow it to not be cost prohibitive so they can introduce and use their skills in our setting? So I'm really happy about your presence, because that means that Medtronic is serious about interacting with us. But I just wanted to see how, sort of, how you saw yourself helping and being a small market, because we have a lot less people than Bogota.
Yes, of course. And also, as Dr. Lucas mentioned, the geography is not easy because you are a little bit isolated.
Yeah.
But I think that with Ports International, we both can face those challenges, and we can help to see the way to have the trainings, also the products that you need. So I think that the way is going to be through Ports. Yes.
So, okay, sounds
But
good.
of course, we are willing to help, and we are willing to support all the trainings.
Thank you.
Also, if you need, for example, virtual trainings, we are willing to do that, and also we can discuss about face-to-face trainings.
Thank
Is
you.
that okay?
Yeah, that's good.
Yeah? Okay. Okay. Thank you very much.
Thank you. Thank you again to Medtronics and Ports International for their continued support through educational collaboration and the provision of surgical supplies and just the care then that we can give. Your partnership remains critical and integral to all ongoing training. And of course, we love to hear about a good CME. So that was a great addition. So we now move forward into our final session in orthopedic surgery. Our first speaker is Dr. Jensen Johnson, consultant orthopedic surgeon at the Princess Margaret Hospital. A proud Bahamian, Dr. Johnson completed his medical training at the University of the West Indies, graduating with honors in 2009 as the most outstanding student of his class. Amazing. He went on to complete orthopedic surgery training there in 2019, followed by a fellowship in sports medicine and arthroscopic surgery at McMaster University in 2024. He will be presenting Precision Redefined, the evolution of minimally invasive orthopedic surgery, highlighting contemporary advances in techniques and outcomes. Please join me in welcoming Dr. Jensen Johnson.
Thank you for that welcome. Don't let all the accolades fool you. I'm not as smart as I sound. So I actually changed the topic a little bit just because I'm not sure if there was another, in the previous sessions, any other orthopedic guys coming in. So I just wanted to give you an overview of arthroscopic surgery. So it's just going to be on the evolution of arthroscopic surgery as soon as we get set up. Okay. Not sure. All right, here we go. So, as I mentioned, we're talking about the evolution of arthroscopic surgery. I'll try not to bore you guys, and I'll try to stick within 15 minutes allotted. I have no disclosures. So, arthroscopy is a minimally invasive procedure used to examine and treat conditions inside synovial joints. Usually involves. Hello? Better? All right. So, yeah. As I mentioned, arthroscopic surgeries is a minimally invasive procedure used to examine, treat conditions inside the synovial joints. It typically uses a fiber optic camera, as you can see here. This is actually the scope, called an arthroscope, into the joint through very small incisions. And the scope can come in, you see here, in both 30 degrees and 70 degrees. What makes arthroscopy very important, as with most endoscopic procedures, is that you can do diagnostic and therapeutic procedures and treat patients in real time as you do it, and is actually considered the gold standard in terms of diagnosis. So it's commonly used in knee, shoulder, hip, and more recent times it's even used in ankle and wrist and elbow. So the case use has expanded quite a bit. These joints are pretty prone to internal derangements, such as cartilage injuries, ligament tears, and so you can treat these adequately through minimally invasive techniques. So we're looking at the pre-arthroscopic era. Surgeons relied on very wide open arthrotomies, which required large incisions to access the joint. These procedures often resulted in significant tissue damage, could result in significant morbidity and infection. So just an example. So this is actually, we're looking at pictures of somebody who had ACL reconstruction. So when you look on the picture over here on your right, this is a wide open incision that goes through the patella tendon. Just to orient you, this is proximal up top, distal at the bottom, and that wide open space is where the ACL should be. Whereas compared to these days, you can do this through 3 incisions, 2 for one working portal, 1 scope portal, and 1 here really just to harvest your hamstring. And again, looking at the shoulder, this is a procedure used to repair the labrum in patients who have had shoulder dislocations. So this here is a wide open shoulder incision. The humeral head is actually being retracted by this retractor here. And what you're looking at, that white portion, is the glenoid with sutures coming out to repair. Fast forward to when we could actually do minimally invasive procedures. You can do the same thing through multiple small incisions. Patients will thank you for it. And then finally, I think one of the most remarkable advances when it comes to hip surgery. So one of the conditions we think of is femoral acetabular impingement, where the femoral head is abnormally shaped. And so back in the day, they used these wide open incisions, dislocated the hip joint just to get to this small little bump here, right? Puts them at risk for infection. Avascular necrosis was a serious risk. And so when we involved into minimally invasive surgery, you can do the same thing through 3 small incisions, as you can see on the picture on your right. So it's a little hard it doesn't come across very well, I don't think, but at the bottom is the arthroscopic view of the hip joint. And the arrow is pointing to that same small little bump that you notice over here. And the bottom picture is where that bump is removed, all through small incisions as noted. So just getting into a bit of the origins. The origins of arthroscopy lie in the development of endoscopy during the 19th century. And we have instruments like the cystoscope to thank for our procedures. However, the early cystoscopes had very poor lighting and limited clarity, which restricted their use. So just a little historical data. So on the right, this is a self-portrait of a guy named Philip Bozzini. He actually invented the first histoscope back in 1806. Now, he was very proud of it and actually went to the Rome Academy of Medicine to present his invention, and he was immediately scorned. They didn't think it was very good. He used candlelight to actually light and view, and it's very poor visualization. So he put it down, and unfortunately he died in 1809, just 3 years after typhus. So he put it down, but 50 years later, a gentleman by the name of Antonin Jean Desormeaux, excuse my French, picked it back up and said, well, this might have been a good idea. He used a different material to now light it and improved on the visualization. And lo and behold, some people accepted it. Still not widespread, but he did a lot better. And then in 1876, Maximilian Neitz, a German guy, looked at it again and further improved on the visualization by improving the lighting. I think he burned tungsten as a material to improve. That's some of the same material that was in the old light bulbs, right? So coming to the arthroscopic part, this gentleman named Dr. Michael Berman, he was from North America. He heard about these stuff being done in Germany and decided to fly over to see, or travel over to see what was happening there, see how he could apply it to orthopedic surgery. And he actually did one of the first arthroscopic procedures and coined the term arthroscopy in 1912. However, it didn't gain wide acceptance. But it wasn't until this gentleman here, Dr. Masaki Watanabe, came up and further improved on the visualization. He invented the scope and he named it the Watanabe number 21. I assume it's because it is a 21 iteration, with improved optics to view better. And this standardized the techniques that we use today. And as you can see in the picture, this is how they did it. Similar to what other endoscopy procedures were done. You had to put your eye right on the scope to see what was going on. So just a little bit of the local experience and the history. There are some names you see up here. Some of you may know them, some of you may not. Dr. Robert Gibson, Dr. David Barnett, Dr. Winston Phillips, who's still practicing here, and Dr. Danebo, who is retired but still in practice. These are the people who did a lot of arthroscopy surgery and still doing so. But I want to focus on this gentleman here. He was actually one of the pioneers of Bahamian arthroscopic surgery. He finished his orthopedic training in New York around 1885. But then he saw a need for 1985, sorry. He is kind of old, sorry. Don't tell him I said that. But he realized there was a need for arthroscopic surgery. And so he went off, trained himself, paid for his own training, and came back and sort of introduced it to the population. Now, in his own words, there were a whole lot of roadblocks, especially, you guys know we work at PMH. So there are lots of roadblocks to progress. So he took matters into his own hands, purchased his own equipment, and started to treat our people, right? And he spent more than 25 years in service. And unfortunately, or fortunately, now we have 2 fellowship-trained arthroscopy surgeons, but we're kind of almost in the same boat now. We don't have equipment, and so we now have to follow in his footsteps and break through these roadblocks. So just to let you know, we have advanced quite a bit. Now we have fiber optics, video systems. As you can see here, this is a typical setup of an arthroscopic tower. It has the video system. It has a pump that we use to infuse saline into the joint for visualization. And it has the fiber optic cable. And with these equipments coming in, it actually caused global adoption. So arthroscopy is actually one of the most common orthopedic procedures performed worldwide. And further advancements today, we actually have this thing called a nanoscope. This is developed by Arthrex. It is actually 1.9 millimeters in diameter, and you can use it to view in the joint. And they also have something called a panoscope. Forgive me, very short video. So this tells you the visualization that you get from their panoscope now. So before, that small field of view is what you would see from a 30-degree scope. And oftentimes you would have to change scopes if you wanted to get a different advantage to a 70-degree. Now they have it all in one scope. You can change your field of view, you can see a wider field of view, and therefore you can treat your patients better and potentially avoid mishaps. And then our techniques have evolved and become more precise. We use pretty standard portal placements around the shoulder, around the hip, and around the knee to get to access to where we want to go. The irrigation systems have improved quite a bit to prevent bleeding or slow down bleeding and improve visualization. And we use specialized equipments. For example, in here you see some shavers and burrs. And we also have more advanced equipment. So these are some suture anchors that we use. We have evolved. I don't have the picture here, but the suture anchors used to be metallic, and some people still have them. They have changed now mostly to become these plastic-looking screws that actually integrate into the bone over time. And even more so evolved, as you can look over a picture on your left, there are suture anchors now that are all suture. So they take up less space in the bone, and they have excellent pull-out strength. And even more so, instead of having to tie a knot in the picture on your right, over here, you have a knotless anchor in which you can feed the sutures through, fasten it into the bone, and you don't have to tie any knots at all. And these make surgeries a lot quicker, more efficient. So in modern arthroscopy, we can do things like ACR reconstructions, as I said before, as the picture up top. And then in the picture in the bottom, you can see here, you may not recognize it, but this is an arthroscopic view of a rotator cuff tear. So here in this picture, I don't know if you can see the pointer. This is the supraspinatus for the residents for your anatomy. You should not be from this view. You shouldn't be able to see the humeral head, which you can see here. So that's a supraspinatus tear. And arthroscopically, we can repair that with these suture anchors here. And it actually gives really excellent results. Just so you could see the high definition views, it may not project high definition, but this is what we see. This is a bucket handle meniscus tear. And you can see the view of the meniscus quite well. This is a medial meniscus with the probe pointing out where it is. And even we have equipment that we can repair the meniscus all inside without having to make any other incisions. Just what we call all inside meniscal repair devices that has really revolutionized the way we repair menisci. And then when we look at the outcomes, of course, less pain, faster recovery, low infection risk, as in most endoscopic procedures. And in fact, we have this, just an example, there's a study done by Boster et al. That showed, we talked about it before, open dislocation of the hip versus arthroscopy. And it actually showed that the outcomes were better, less pain, less risk of infection. And so most procedures nowadays in terms of hip are done arthroscopically. Some of the limitations we have, training, it can be technically difficult to learn, especially when you look at the hip arthroscopy. However, nowadays we have residents who are coming up who have played a lot of video games, and so they catch on to things extremely quickly. And arthroscopy is not for all patients. If you look at the picture down here, this is very advanced osteoarthritis, and so arthroscopy would not be the ideal treatment for this. I think in the future we'll move more and more toward doing things arthroscopically to treat osteoarthritis, but for now, it's contraindicated. And then when we look at the future, there's robotics, as mentioned before in some of the previous talks. AI integration is a big thing. Regenerative medicine in terms of trying to regrow cartilage, and office arthroscopy. So this is an example of the AI integration. So this is the same femoral acetabular impingement. If you look here, the colored portion is the CAM lesion, which actually causes the impingement. And with AI, you can actually map that cam lesion out properly so that when you're intra-op, you know how much bone to take off, where to take it off, and it makes you more efficient and more accurate. And so people are developing apps now to be able to do this intra-op. And then the office arthroscopy that we mentioned before. Imagine your patient coming to coming to your office. They have a problem with a knee. And instead of just maybe sending them for an MRI like we do usually, you just poke the scope inside and you see what's going on. Very much limited pain, very efficient. And right now it's limited for diagnostic scopes, but soon you're going to be doing therapeutic things with it too. So imagine all of this stuff happening in the office. And so in conclusion, I think I stuck on time. Arthroscopy is a major, major surgical advancement. And the innovation is continuing almost every year. Something new comes out. It would be nice for us here if we could advance along with it. And that's part of my task, to push the limits and get arthroscopy really going at PMH. So thank you very much. Any questions?
Dr. Chambers can answer. Where are
Nominate
we in
Dr. Grimes.
Where are we in terms of introducing arthroscopy in select cases or elective procedures at PMH? What is needed except money? And is there a stepwise plan to try and implement same?
What is needed? That was
Other
the
than
question. Except money?
Yeah, and where are we in terms of?
That's what we need. So there are plans right now. We've put in for orders to get new arthroscopic towers because we actually had one and still there, but unfortunately it's outdated and non-functional. So one of the first things we have to do is get the tower there. So we will be looking at, as mentioned before, private-public partnerships and trying to get and implement same. As it goes to a timeline, that's. I've been waiting about 2 years. I don't. The plans are already made. It's just the implementation.
Colleagues across the Caribbean agree. In every area of surgery that's advanced, we push it. And I think Dr. Lucas is seeing that most recently. Dr. Johnson is seeing it. I would be interested in hear what my colleagues from away think. But what I would say is we have to be the drivers, and let's just drive it, and it'll happen. And otherwise, I went through the same journey in spine. If I was waiting for stuff, I wouldn't been able to do anything. And I just fixed someone with a 2-level lumbar burst fracture yesterday with stuff that doesn't technically exist there. So I think let's just push it and it'll happen.
That's what we're talking about.
we had it, it's not that it was never here. When I came back from training, there was a public-private partnership whereby patients would pay a small fee and a private company would provide scope. And then when we moved from the old operating to the CCD, they had arthroscopy. There was a tower that was still there, and we were able to do arthroscopy procedures. But as in everything else, maintenance is an issue. Replacement of parts when needed, that's an issue. And so now we have nothing, except that we have had orders in for stuff from before COVID, I think. So yeah.
It's a situation where we have the personnel, we have the training, we have the expertise, and just the equipment. Thank you very much.
Thank you, Dr. Johnson. So I think that's it. So thank you to all the presenters this morning. It has been we've had really good sessions, rich in insight, precision, shared expertise. It was really a wonderful group of sessions. So let's just applaud all of our speakers this morning. From laparoscopic innovation to complex oncological decision making and into evolving cardiovascular frontiers, we've been reminded that progress in surgery is never accidental. It is deliberate, it is disciplined, and continuously refined through exchanges just like this one. So we will now take a short break and reconvene at 4 p.m. for your hands-on lectures and workshop this afternoon, where today's concepts move discussion into practice. Thank you all so much, and see you this afternoon. At the Pfizer building? No. Oh, by PACU, by PACU's waiting area. That is where the session will be this afternoon, 4 p.m.